has had a good breakfast. I welcome you all on the land of diversities, uh, land of Kutch for Fetuscan 2023. It's like one of its kind and first event under our beloved President Dr. Puneet Khatri sir. I would like to start the session with small Saraswati mantra, goddess of knowledge and Vidya. Ya Devi Sarvabhushteshu Buddhi Rupene Sanstita Namastasye 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 Namo Namaha. Our first session is ISUOG guidelines on mid-trimester scan, and it is taken by Dr. Hemangini Bajana. I request Dr. Hemangini to come on the stage. She has done her MBBS and DGU from Nanavati Hospital, Mumbai. ICUG or recognized fellowship in fetal medicine under the guidance of Dr. Jaiprakash Shah in Laban. She was class 1 gynecologist at Government Hospital Nakhatrana for 3 years and presently working as fetal medicine consultant at Devashish Hospital. To chair the session, I would like to request Dr. Shailendra sir to come on the stage, Dr. Prafulla Ben and Dr. Shivam Kotak. Please come on the stage. Thank you.
Namaste and good morning to everyone present here, especially the guest of honors, Dr. Suresh sir, Dr. Swati ma'am, Dr. Mayank Chaudhary sir and Dr. Dhiren sir, and to the chairpersons. Today I'm going to present on ICOG guidelines on mid-trimester scan. So starting with any antenatal scan, ICOG has given 6-step approach in which first we have to keep the transducer, transverse and perpendicular just above the pubic symphysis to see for the fetal presentation, that is cephalic breech or transverse. From this first step, we have to go upwards towards the umbilicus to see for the fetal cardiac activity. If we don't get over there, or we have to go to the maternal left or maternal right for it. The third step is to see for the number of fetuses. For that, we have to go from transversely from lower part of the uterus to the upper part of the uterus in all 3 quadrants. And then from upper part of the uterine cavity, we have to go downwards like shown in the figure for placental location in number 1, 2 and 3 as shown in the image. 5th step is to measure the amniotic fluid volume. For that, we all know that we measure 4 quadrants of the uterus, and the 6th step is to measure the fetal biometry. So what do we evaluate in mid-trimester scan? We evaluate cardiac activity, number of fetuses, its chorionicity and amniocity in multiple pregnancies, gestational age or fetal size, then basic fetal anatomy, placental appearances, location, and amniotic fluid volume. To whom we should offer mid-trimester scan? So in many places, first trimester scan is routinely practiced to assess, to accurately date the pregnancy if the patient does not remember the LMP or have irregular periods, then to rule out chorionicity in multiple pregnancies, and also to evaluate uterine and adnexal masses. But in some places, especially where I practice, the people doesn't afford much scans. So at least a mid-trimester scan should be done to everyone, because even few anomalies cannot be detected at first trimester scan. So at which gestational age this is preferred? It is preferred at 18 to 24 weeks, but preferably at 21 to 22 weeks. Okay. So ICOG has given this proforma which covers all the details, all the biometry and all the fetal anatomy which we routinely see at mid-trimester scan. So we start with the examination by evaluating the fetal size, and it includes biparietal diameter, head circumference, abdominal circumference, and femoral length. If the mother has not undergone first trimester scan and they don't know their LMP and have irregular cycles, then dating can be done at mid-trimester scan by measuring HC and FL. So for measuring biparietal diameter, first we have to take a transverse view of fetal head at the level of thalami or lateral ventricle. The ideal angle of insonation should be 90° to the midline echoes, and there should be symmetrical appearance of both the hemispheres. Midline falx should be visible, only interrupted anteriorly by the cavum septum pellucidum, which is usually rectangular in shape, and cerebellum should not be visible at this level. Now the calipers are placed for BPD measurement either outer edge of the bony margins to the inner edge, or outer to outer edge at the widest part of the skull and perpendicular to the falx cerebelli. Outer to outer is preferable because it eases standardization, reproducibility, and quality control. Cephalic index is calculated by biparietal diameter to characterize the fetal head shape, because in some cases where there is brachycephaly or dolichocephaly, it indicates some side of syndromes or oligohydramnios or breech presentation. And in this case, if we take BPD to evaluate the fetal age, then the measurements are inaccurate. For measuring head circumference, we have two approaches, either eclipse approach or by measuring biparietal diameter and occipitofrontal diameter. In eclipse approach, we just have to place the calipers on the outer edge of the bony margins, and in BPD we know, and for occipitofrontal diameter we just have to keep the calipers on the outer edge of the frontal and occipital bones at the midline falx level, and then we can measure the HC by given formula. For abdominal circumference, we have to take a fetal abdominal section, transverse section. It should be as circular as possible, and the fetal spine is preferred at 3 o'clock or 9 o'clock position. And it can be measured either by eclipse approach or by measuring the transverse abdominal diameter, that is at the widest part of the abdomen, or by anteroposterior abdominal diameter, in which the calipers are placed at the skin behind the spine to the anti-abdominal wall, and then it is calculated by the formula. Femoral length, the ideal angle of insonation for it is 45 to 90°, and the calipers are placed at the longest axis of the ossified diaphysis. The epiphysis or the triangular spur artificate should not be included in it, because it will give a false length. And then by all these measurements, by Hadlock 3 formula, we measure the estimated fetal weight, and any variation in the fetal size with the mean gestational age should be expressed in centiles or Z-score. Estimated fetal weight is useful for predicting subsequent fetal growth restrictions. Amniotic fluid volume, it is measured by two formulas: deep vertical pocket or amniotic fluid volume. In deep vertical pocket, we have to measure a single largest pocket, which should not include the fetal part or the umbilical cord. Its normal value is 2 to 8 centimeter. And amniotic fluid volume is measured by measuring the 4 quadrants of the uterine cavity, in which the transducer should be perpendicular to the ground, and it should not include fetal part or cord. Fetal movements, normally the fetal is in neutral position and have regular movements. We don't see temporary absence of movements as a risk factor, but if there is abnormal positioning, or there is restricted movement, or there is persistently absent movement of the fetus, it suggests conditions like arthrogryposis. Umbilical cord insertion to the placenta is not routinely seen in mid-trimester scan, but if there is marginal insertion or velamentous insertion of the cord, it should be noted and further evaluated. So number of umbilical arteries, if there is single umbilical artery, it may coexist with structural defects or FGR, but if it is not there, then it is not an anomaly per se. It can be seen by putting color Doppler around the bladder, and we can see both the arteries going around it. Doppler is used in assessing fetal heart, cord vessels, amniotic fluid volume, and taking the Doppler measurements. Multiple gestation, the chorionicity should be determined in the first trimester itself, but if it is not possible, then and if during mid-trimester scan two separate placentas are not seen, and if the fetal gender is same, then the pregnancy is considered monochorionic itself. Now coming to the anatomical survey, first the head. So in head, we basically measure the fetal skull size, shape, its integrity, and bone density. And for this, we take three basic axial views, that is transventricular view, transthalamic view, and transcerebellar view. As shown in the video, it is just a few seconds swipe. We can take all three views of the head. So for size, we already know that we measure biparatal diameter and head circumference. Shape, there should be oval shape of the head, and there should be no protrusions. The skull bones should be intact, and also for determining that there is a good bone mineralization, shadowing should be seen behind the bones like this. And at this in skull, we see few structures such as lateral ventricle, which we measure at parieto-occipital diameter. Its level should not be more than 10 mm. Then we see the thalami, we don't measure it. And at transcerebellar level, we measure the dumbbell-shaped cerebellum, then the cisterna magna behind it. It should not be more than 10 mm. And the knuckle fold is measured from the occipital bone to the skin. In face, we see for the lips, nose, nostrils, both orbits and the lens within it routinely. And the other views that we can see, but it's not compulsory, are fetal profile view to see the nasal bone, maxilla, hard palate, mandible, tongue, and at last we can give a patient a beautiful three-dimensional pic. So the patient is happy. Neck. In neck, we see that the neck is cylindrical. If there is any neck masses like cystic hygroma or goiter, we just have to go for further evaluation. Thorax. For thorax, we have to assess that the shape of the thorax is regular and there is smooth transition of the thorax to the abdomen, and the ribs should be regular. It covers 2/3 of the circumference, and both the lungs should appear homogeneous. There should not be any solid or cystic masses within it, neither be there should be a midline shift. And even we see for the diaphragm interface as a hypoechoic dividing line between the chest and the abdomen. For heart, we always start with the situs. Then we see for the rhythm, axis, and anatomical examinations like four-chamber view, both the outflow tracks and the three-vessel view. But for heart, for any views, we just have to keep the narrow window, one focus, and the screen should be maximized. The thing that we have to see should be maximized 1/3 or half of the screen. Coming to the situs. So, do you think this is a normal situs? Stomach and four-chamber view on the same side of the fetus, right? Yes? No. I would say no, because I don't know fetal presentation, whether it is cephalic, breech, or transverse. Okay, so unless you don't know the fetal presentation, you can't see it normal. If it is a cephalic presentation, absolutely this is normal. But if it's breech presentation, then it is situs inversus totalis. So for seeing situs, we have two methods. One is when there is cephalic presentation, we see spine, stomach, and portal turning to right in clockwise direction. And if it is anti-clockwise direction and breech, then the situs is normal. The other, an easy method, you just see where is the fetal head and you imagine your feast on the fetal head. And the way the open thumb goes, that side, your heart and the stomach of the fetus should be. Okay, so it gets very easy. Then we come to the four-chamber view. In this, we see intact ventricular septum. The flow through the atria and ventricle should be easy. Valves should be opening very easily. And when we keep low PRF, we can even see the pulmonaries inserting into the left side of the heart. Then comes the left outflow tract, in which the major first vessel of the heart comes out from the left ventricle, that is the aorta. Then just going upwards from there, we get the right outflow tract, that is the second largest vessel, main pulmonary artery, which branches immediately after coming out from the right ventricle into pulmonaries. And then comes the three vessel view, where the largest one is pulmonary, aorta, and then the superior vena cava. These four are compulsory. The rest we take it for our things. That is three vessel trachea view, in which the aorta and the pulmonary merges over here, and we can see ductus arteriosus, or we can measure it over here. And then we take right subclavian artery, which goes in front of the trachea. We take it because it is a soft marker for trisomy 21 in second trimester scan. So it hardly takes a swipe from situs to the right subclavian artery, a few seconds, right? Once you get practice. When my sir was telling me that it's just a swipe, I used to feel like, when will I be able to do it? But yes, actually, if you do practice, it's just a swipe, and it's very easy when you have a normal heart. Okay, so 4-chamber view, then the right outflow tract was there, left outflow tract, three vessel view, three vessel trachea view, and the right subclavian artery. So normal heart just covers 1/3 of the area of the chest without pericardial effusion, and the axis of the heart is normally 45 degree plus or minus 20 degree. You can measure it by this way. One line is passed from the ventricular body to the anti-abdominal wall, and the other line is passed from the interventricular septum, and the angle between it is the heart axis. Coming to the abdomen, situs we have already discussed. So in heart, what do we, in abdominal circumference, what do we see? We see four structures, okay? So first is the stomach. Stomach should cover at least 1/3 of the left half of the fetal abdomen. Then we see the portal turning to the right. If it is not turning to the right, it is turning to the left, then it is a type of anomaly. Then we see aorta on the left side of the spine, and we see IVC on the right side and just little above to the aorta. If we don't see these four structures at the abdominal circumference, then there is something wrong. Then in abdomen, there comes bowel, which should be within the abdomen, neither in the chest nor coming out of the umbilical cord insertion site. So also umbilical cord insertion site should be evaluated. Also fluid collection, if in the bowel, should be evaluated. And if you see that the intestines, bowel are appearing ecogenic to you, then you just decrease the scale. And if you see it more ecogenic than the adjacent bones, then it is definitely ecogenic. Kidneys and bladder. So for bladder, you just see at the like cord insertion site and in the sagittal view. If you see bladder going above the umbilical cord insertion site, then just measure it. It should not be more than 23 mm. And for seeing kidneys, there are three ways. First is a sagittal view, in which you take sagittal view of the spine, then just come little forward to it, you will see one kidney. Just again go to spine, then just go little behind, you'll see the other kidney, right? Or here is the one kidney and here is the second one. Then you can even see it by coronal section. Here are the two kidneys, and you can even see in transverse section. You can even take help of color Doppler. You can see the renal artery supplying it. And if you feel that there is a renal pelvis dilatation, you can measure it in transverse section by measuring the renal pelvis over here. Spine we see by sagittal section, or we take a beautiful 3D picture, which is always not possible. But major spinal abnormalities like open spina bifida is always associated with cerebellar deformity, so it is easy to find out. But few abnormalities like hemivertebra or sacral agenesis, sagittal view is very helpful. In limbs, we see all four limbs of the fetus, each and every part of the limbs, but we don't measure each and every bone. So we mostly measure femoral length or humerus, okay? And we don't count fingers or toes. It is not a routine practice. But yes, we always have to see for the alignment of the limbs. That is, foot is properly aligned to the lower leg to rule out club foot. Okay, and this is the hand and this is the leg. We only measure all the limbs whenever we suspect for skeletal dysplasia. Genitalia, obviously we don't see in India, so we don't mention anything about it. Placenta, We have to see for the placenta's lower edge relationship with the cervical os. If it is less than 15 mm by transvaginal scan, then it should be noted and it should be evaluated in third trimester. Also, if there is abnormal placental findings like hemorrhage, or there is multiple anechoic cyst, or if there is a placental mass, it should be evaluated further. And if the patient has undergone any uterine surgeries, we should surely evaluate for placenta accreta. And the last thing we evaluate is the cervical length. Okay, so preferably cervical length is taken by transvaginal scan. If patient does not allow you, then only you have to take it by transabdominal scan. And if the cervical length is less than 25 mm by TBS, and if the patient has previous history of preterm birth, then you definitely have to consider for the risk of preterm birth. Thank you so much for listening.
Thank you, Hemangini Ba, for such a wonderful session. I'll request chairpersons and Dr. Hemangini Ba to come on the stage. I'll request our chairpersons to give a memento to Dr. Hemangini Ba. We would like to have a group photograph also.
Hello, a very good morning to all of you. Now I would like to invite our guest, our faculty, Dr. Swati Thakkar ma'am. She did her obstetric and gynec from NHL Medical College and did her fetal medicine fellowship from Mediscan System Chennai under the guidance of Professor S. Suresh, and she did training at King's Hospital UK, Professor Kipro Nicolaides, and at present working as a fetal medicine consultant at Dr. Hiren Doshi Clinic and Mayflower Women's Hospital, Ahmedabad. And I would like to invite our chairperson to chair the session, Dr. K.G. Vaishnav sir, Dr. Naresh Bhanusadi sir, and Dr. Ashwin Pansurya sir. I welcome Swati Thakkar ma'am on the dais. Welcome ma'am.
Thank you so much for the kind words, ma'am. A very good morning to one and all. At the offset, I would really like to thank Bhuj Obstetric and Gynec Society for giving me this opportunity. Wonderful people, wonderful place, wonderful weather. Thank you so much. So, my topic today is first trimester scan. We all know that the pyramid of antenatal care, which used to be in a form that initially patient used to take infrequent visits and frequent visits in the late trimesters. But since past few years, it has been reversed. Reversed in the sense that when patient comes for the first time, she is categorized into two categories, either in a high risk or a low risk category. If she is under high risk category, initially she'll take specialized visits and then some frequent visits if needed, and low risk patient will be given normal antenatal visits first in first trimester, thereafter 2 in second trimester, and frequent needed in third trimester. So, first trimester scan, we usually listen that it is traditionally said an anti-scan. Is it really just an anti-scan? I would say no. Let's see why no and how. So, first trimester scan is useful to date the pregnancy, for various type of screenings, to see the fetal anatomy, for establishing cogenicity in multiple gestations. Let's see one by one. The importance of dating. It is rightly been said by Dr. Professor S. Suresh sir that the biggest advantage of dating the pregnancy is that it can solve the puzzle of fetal growth restriction correctly in the third trimester. For example, if the patient is a delayed conception and you have not assigned her gestational age, you will be solving the complicated puzzle of fetal growth restriction in the third trimester, right? To assess the fetal growth and for time-specific prenatal testing of first and second trimester screenings. Now, it is very wise. We all know that how to measure the CRL, right? According to FMF criteria. I will not go in detail of how to measure the but it is always wise to take a cine look. Okay, when the fetus is moving in the first trimester, you take a cine look, then you go image by image, whichever is best you can take. The goal should be take the good and image close to an ideal one, right? So, how will you assign the gestational age and when will you assign the gestational age? In first trimester, you will assign the gestational age by crown rump length. You measure the CRL, you calculate the EDD by last menstrual period and EDD by gestational age by CRL. So, if the difference of that gestational age is more than 5 days in less than 10 weeks of gestation, or if it is more than 7 days in 11 to 14 weeks of gestation, you should assign the gestational age by CRL. In the patient where there are irregular cycles or very short cycles, you should assign the gestational age by CRL. In case of IVF conception, you assign the date with embryo transfer or blastocyst transfer date. And in multiple gestation natural conception, you consider the larger CRL, right? The thing which must be kept in mind is once the gestational age is assigned, it should never be changed. Never ever be changed. So you should not give a different EDD each and every time according to the growth of the baby. Once you have assigned the gestational age, that is the final date for the patient. Yeah. Now, the second use is for aneuploidy screening. There are 4 major markers of Down syndrome in the first trimester. That is knuckle translucency. The position of the fetus should be such that it occupies the head and thorax only. It should be in a neutral position. The brightest and widest part of the nuchal translucency should be taken in account. The caliper should be on and on. We all know all these things. So for nasal bone, there should be 3 echogenic lines. The one on the top is keen over the nasal bone. This is the nasal bone, and this is tip of the nose. For tricuspid regurgitation, the regurgitant flow should occupy at least half of the systolic flow, and this is reversal of ductus venosus. Now, adding tricuspid regurgitation and ductus venosus reversal into the screening will reduce the false positive rates. So, this is a very important slide. We have seen referrals with NT 3.5 and advice of termination. If you can see here, the nuchal translucency between 3.5 to 4.4 has an adverse outcome of 21%. But you can think that rest 79% has good outcome. So it is wise to investigate and then advise for the termination. Now, screenings, only maternal age has a detection rate of 30%. Biochemical markers only, that is beta HCG and PEPE, has a detection rate of 50%. If you add USG markers, that is nuchal translucency and nasal bone, gives you a detection rate of almost 90%. And the non-invasive prenatal testing has a detection rate for Down syndrome of 99.9%. The next important screening is preeclampsia. In an era of stressful life and advanced maternal age, the rates of preeclampsia are increasing day by day. So how can we screen the preeclampsia? You take maternal age in account, you take her history of prior pregnancies or family history, placental growth factor, PEPE hormone, and a good screening of uterine artery in first trimester itself according to FMF criteria. Once you take all these things, and the software will give you a risk of preeclampsia. If she comes under high risk of preeclampsia, you can start ecosprin 150 mg in first trimester itself. As we all know that it should be started before 16 weeks of gestation. So this is a use of first trimester scan when you scan the patient. Next important thing is establishing the chorionicity in multiple gestation. As Dr. Hemanginiba said, that it is difficult to establish chorionicity in second trimester due to various reasons. So it is always good to establish it in first trimester. And why would you establish the chorionicity? You can manage the twin as a monochorionic twins all throughout the pregnancy. But no, we all know that the complications are much higher in monochorionic twins rather than in dichorionic twins. So it is good to establish chorionicity. So this here you can see there are 2 different placentas, A and B. So it is very easy that they are dichorionic twins. But when you see a single placenta, and with that if you see a lambda sign, that is dichorionic diamniotic twins. But if you see that there is no lambda sign and the membrane is thin there, that is monochorionic twins. And if you don't see any membrane in between and there is a single placenta, that is monochorionic, monoamniotic twins. The most important part of the first trimester scan, anatomy scan, that is an anomaly scan now, because you have a good opportunity to see the fetal anatomy at 11 to 14 weeks of gestation, and major structural defects can be detected at this scan itself. The advantage is you can open the option of termination in a case of lethal anomalies, and there's less emotional trauma to the mother. Now, these are the ESOC guidelines, which I'll elaborate in detail at the last in a simplest form. Okay, there are things which are mandatory, there are things which are optional. But before jumping on to the anatomy, it is very, very, very important that you start with a survey. That means whether the pregnancy is intrauterine, you check for the environment of the fetus, that is placenta, location of the placenta, the fluid around the baby in a subjective form, and the fetus itself. So start with the survey. Even though the fetus is in a very good position, you are tempted to take an anti. No, before that you start with the survey. Okay, now let's go one by one with the head. So in head, we take two sections, transventricular section and transthalamic section. The first is transventricular section, wherein you will see midline falx, choroid plexus, snugly fitted in the lateral ventricle. Most of the time they are asymmetrical, so don't bother for that. And intact cranial bone, which is very important. Now, in transthalamic plane, thalami, aqueduct of Sylvius, and cerebral peduncles. Now, coming to the next, in neck. In neck, very lots of the time you will see neck masses because they are most of the time evolving. In coronal view, you may see jugular sacs, and in sagittal view of the face, that you may see the neck masses. You can see many other informations, that is a nasal bone as I described previously, then thalamus, brainstem, the intracranial translucency or future fourth ventricle. The choroid plexus and cisterna magna. Now in face, in sagittal view, as I described, you see all those informations, plus when you turn the probe 90 degree, you will be seeing two eyelenses and premaxillary triangle, the apex of which is made up of nasal bone, the sides by maxillary processes, the base by maxilloalveolar ridge, and two mandibular dots. In chest, you will be seeing two symmetric lung fields with no effusion or mass. The heart and the lungs are occupying the same space in the chest. Now, according to new ESOC guidelines, we are allowed to take color flow, that is color Doppler, in a limitation. So, according to ESOC first trimester guidelines, it is mandatory to take cardiac regular activity. But we can also see 4-chamber color view. These are two inflows and an arch view. Arch view I will describe in detail in my next talk, which is very important. So, if the patient is a very low BMI patient and a good resolution machine, you can also take two outflow tracks, that is left outflow track and right outflow track in first trimester itself. Now spine, you can take a coronal view where you can see two vertebral bodies lying, and in a sagittal section you can see an overlying skin. You can diagnose major spinal defects, that is spina bifida, or you can see the shape of the spine if it is altered in a form of kyphosis or scoliosis. Now in abdomen, stomach and a bladder. Stomach, which is present in the upper abdomen below the diaphragm, which is important, and a bladder, both are anechoic spaces. Now, kidneys are not mandatory according to the guidelines, but we do take 2 renal vessels in each and every patient, and if possible, we also document 2 kidneys. In abdominal wall, normal cord insertion with no umbilical defects, and 3 vessel cord, which is again not mandatory, and even if you see a single umbilical artery in the first trimester, it is wise not to report in first trimester because the false positive rates of single umbilical artery are very high in first trimester. And in extremities, we take all 4 limbs with each 3 segments of them. that is a proximal segment, a middle segment, and a distal segment. And the orientation of hands and feet. Again, even if you see the talipus in your first examination, don't always document that in your very first examination. You always confirm the diagnosis after a few days and then only you document it. And open hands are very easy to see in first trimester. Again, for your ease, you can also take a clip like this. We always take a clip so that it is easy to see the limbs. Now, genitalia, evaluation of genital tubercle is upon the orientation. So, the male genital tubercle is perpendicular to the spine and the female, as shown here, is parallel to the spine. Last but not least, the placenta and the cervix. The location of the placenta, the homogeneity of the placenta, and length of the cervix. Low-lying placenta. If the patient has a strong history of bleeding, you can mention that it is low-lying. But don't mention placenta previa in the first trimester because placenta can migrate thereafter. Now, these are some anomalies which were commonly diagnosed in first trimester in Mediscan. The highest was on multisystem anomalies, followed by CNS anomalies, and followed by musculoskeletal. And the anomalies which are tend to missed were genitourinary tract anomalies because they are most of the time evolving anomalies, and cardiovascular, which may be difficult to diagnose or many a times is evolving. Now, this is a list of anomalies which are always detectable, which are potentially detectable, and which are undetectable, or because they are late evolving anomalies, we cannot see it in first trimester. Nowadays, with good machines and with expertise, many of these potentially detectable anomalies are also being diagnosed in first trimester itself. Now, this is a paper which shows that which are the major defects which can be diagnosed in euploid fetuses in first and second trimester. The message here is, if you stick on to your protocols, if you follow the standard views, it is really not easy. It is difficult to miss the always detectable anomalies. So we'll see some common always detectable anomalies. Here, if you remember, I had shown the normal view of the head, the intact calvarium. This is a case, if you see this clip, you cannot see the shape of the head, which is normal. The brain is floating into the liquor. And here you can see the frog-like image. So this is a case of acrania, a very lethal anomaly. The detection rate should and is 100%. The encephalocele, wherein the protrusion of meninges into the hernia from the skull wall. So the skull wall is not intact. This can be a multifactorial anomaly, can be isolated or can be syndromic. But this can be seen only when you have a good amount of fluid behind the head. Otherwise, if it is stuck into the placenta, you may miss this anomaly. Holoprosencephaly. You can see that in normal case, we should see the midline falx and two choroid plexus. Here you can see there is a single ventricle with a cystic cavity behind. So the brain is not divided into two parts. This anomaly has high chances of aneuploidy associated with it. It has poor prognosis and most of the time is associated with facial abnormalities. Now, omphalocele, a defect in the abdominal wall. There, the abdominal wall or abdominal organ are herniating out through the defect. The risk of chromosomal abnormality, especially the trisomy 18, is very high. And the prognosis again depends on the content which are herniating through the hernia. Now, this is a fetus with both the omphalocele and the encephalocele. So the chances of aneuploidies are high in this baby. Limb body wall complex, where the cord length is short, there is a defect through umbilical wall. There could be a limb abnormality or spinal deformity. In this case, the diagnosis is very spontaneous, that the fetus is stuck to the placenta. It won't be able to move. And there are defects associated with it. The prognosis is poor, though the chances of chromosomal abnormalities are very low in this case. Now, megacystis, when the vertical diameter of the bladder is more than 7 mm. If it is between 7 to 15 mm, the chances of aneuploidies are high. But again, the spontaneous resolution rate is also high, like 90%. But if the diameter is more than 15 mm, the chances of obstructive uropathies are very high. Now, let's discuss some cases. This was an IVF conception, twins. She had on and off bleeding per vaginal. One baby has normal intracranial translucency and rest of the anatomy also was normal. The other one, you can see here only 2 lines, 1 and 2. So the intracranial translucency was abnormal, which turned out to be, when we did transvaginal scan, was a spina bifida. The placenta was covering the os. We did fetal reduction of that baby and the normal baby was doing good, was delivered at term. So intracranial translucency, if it is abnormal, has high chances of spinal deformities or spina bifida rather. Now this is a second case, an IVF conception, precious pregnancy. Again, if you can see here, the intracranial translucency is abnormal. Patient was counseled accordingly, but she wanted to continue the pregnancy. We could not see any spinal lesion in this case in first trimester. We counseled her that she can come back at 16 weeks, but she wanted to continue the pregnancy besides all odds. She continued the pregnancy. She came back at 20 weeks of gestation, and you can see here it turned out to be dandivocal malformation. And unfortunately, absent flow in the umbilical artery as well. She terminated the pregnancy thereafter. Now again, the same patient in her next pregnancy, twins gestation. One baby was absolutely normal by anatomy, another again abnormal intracranial translucency and reversal of flow in ductus venosus. This time she was ready for fetal reduction. So we did fetal reduction. Again, unfortunate for her, the normal baby had placental hemorrhage with absent and diastolic flow in the umbilical artery at 31 weeks of gestation. And she delivered by cesarean section, but fortunately the baby is doing good now. Third case, as I said, if you can see here, this is a case where you can see clearly that there is a talipus deformity. There is good amount of liquor around the fetus. But we had not documented this in first trimester. We had given a possibility and called her back at 16 weeks of gestation, confirmed the findings again, and then she continued the pregnancy. We did RSCGH, which was normal. She was a doctor patient with a doctor couple, very good friend of mine. They continued the pregnancy. The daughter is 2 years old now. After birth, she was given splint and small tenoplasty was done. At 1 year of age, her first birthday, she was walking normally. So, once you see the abnormality, don't always counsel for the termination of the pregnancy. Look something good, see something positive. Case again, second gravida, previous miscarriage. Her first pregnancy was terminated for increased nuchal translucency, which turned out to be monosomy X. Now, in this pregnancy, this was the finding. The penetration was not that good, but if you can see here, there is a gap at the base of the premaxillary triangle. When I did a transvaginal scan, I could see a cleft lip and palate. She was very determined to continue the pregnancy because her mother was operated for cleft lip and palate. She got her RSCGH because of her previous pregnancy history. She said, I want to get this done. And that was normal. She continued the pregnancy. This baby now is 5 years old, operated and doing good. Now, a question for all of you. Is this normal? Encephalocele? Raise your hand. Normal? Normal, raise your hand. No in between option. Only encephalocele, normal. Encephalocele? Normal? No, sir, with this section only. No sagittal section. This can be diagnosed with this section itself, sir. Encephalocele. So, there is a good amount of liquor. You can see the skull is intact. This is an amniotic membrane. Yeah, good question. Sagittal section. So, you check the fetus from each and every aspect. Okay, before diagnosing encephalocele, you check it in all aspects. Now, this is an ISO guideline in a simplest form, which are the things which are mandatory and which are optional. We do follow rule of 2 of Mediscan. So, whichever things are optional also we check. And once you start scanning, you have your own protocol. You will add on something and something day by day in your protocols, but it is very, very, very important to follow your protocol to recognize the pattern, the normal pattern, what is normal is very important to see. So each and every day when you see what is normal, you will be able to see or you will be able to diagnose what is abnormal very easily. And once you diagnose what is abnormal, check that thing 5 times whether it is normal. Whether it is normal, then only you will be see. And then only you will not miss normal things. It is very important not to miss normal things in nowadays. This is the second slide. So, to sum up, first trimester scan is not just an anti-scan. It is important to date the pregnancy. Highest aneuploidy detection can be done in first trimester scan. Major fetal defects can be diagnosed in first trimester scan itself. It is very, very important to diagnose or establish chorionicity in the first trimester and let us not leave any room for the regrets. Thank you so much.
I'm sure that every one of us gained a lot from your presentation today. Now I'll request our chairperson to give a memento and certificate of appreciation to ma'am. Ma'am, thank you. Thank you, ma'am. I also request Hemangini ma'am for taking certificate of appreciation.
I myself and Dr. Puneet Khatri sir will hand over the certificate of appreciation to Dr. Hemangini Ba.
Thank you so much, Dr. Swati ma'am. Now for the most awaited session of the event. It's a pleasure to have the god of fetal medicine, legendary Professor S. Suresh sir, on the land of Kutch. So we are really grateful to you that you have taken such a lot of pain to travel so long to enlighten us with your knowledge. I still remember way back before 18 to 20 years when I was a resident that there was a waiting of months to get fellowship under Dr. S. Suresh sir. Thank you so much, sir, for taking so much of pain. The topic sir is going to cover is role of first trimester scan in the era of NIPT. To chair the session, I would request Dr. Damayanti ma'am. I think Dr. S. Suresh sir doesn't need any introduction. Then also to complete the formalities, sir has done his MBBS FRCOG honors DSC. He's Director of Mediscan Systems, Chennai, India. He's Honorary Secretary voluntarily, CEO Health Services, Chennai. Visiting Professor in Perinatology, SRMC, Chennai, and PhD Hospital, Coimbatore. He started Mediscan in 1982, the first ultrasound center in Chennai. He was conferred FRCOG by Royal College of Obstetrics and Gynae, London in 2010. He was past president of Indian Federation of Ultrasound in Medicine and Biology. International Society of Ultrasound in Obs and Gynae nominated him as ambassador to India since 2017. Member of Basic Training Task Force of ISCOG. Specialist in fetal medicine and has performed many surgeries, diagnostic and therapeutic. He was trained in fetoscopic surgeries in Necker Hospital, Paris, trained over 5,000 doctors from India and other countries in ultrasound and fetal medicine. He has done over 100 publications, including author of 2 books in fetal medicine. He delivered over 800 lectures and 19 orations across country and internationally. He was awarded Champion of Chennai by KSA Trust in 2018 and is presently transforming VHS Hospital as a destination of truly affordable healthcare with modern facilities. He's a sonologist and his hobbies also include the same. He loves nature and wildlife photography and he's happily married. to Dr. Indrani, and have two sons, Dr. Sudarshan and Arvind. So we would like to hear some very good and knowledgeable things from you. Welcome, sir. Thank you, sir.
Why this title was actually given is we could just have said, what is the role of first time scan today? Because NIPT has become a method of screening. A few years ago, the cost of NIPT was 30,000 rupees. So very few people could afford it, and it was talked about as like meant only for the top level of society. But today, the cost of NIPT has come down so much, and the capability of NIPT has also, we have understood the increased capabilities of detection or screening and accuracy of screening. We realize that this is a very important test. There are several countries who have given up on first trimester biochemical screening and gone for NIPT as the first option. So naturally, we need to know what it's all about. So let me say a few words about NIPT itself. What is NIPT and what's the rationale of that having so much of accuracy as compared to a combined test? Now, the trophoblast of the fetus throws out. There are cells in the trophoblast, and these cells contain DNA, and they break open from the cells, and they are freely floating in the circulation. And these cell-free DNA actually go into the maternal circulation. So mother has got a DNA composition, and mother also has, all of us have DNA floating outside of the cells. So that's what we call a cell-free DNA. And the fetal cell-free DNA is also coming. So if we find a method to differentiate between the maternal DNA and fetal DNA, we have the opportunity to go and investigate the fetus through the mother without any invasive testing. But you realize that the amount of cell-free DNA that can come from the fetus to the mother is extremely small. So we need a certain minimum quantity before we can actually be able to test for it. And the minimum quantity that has been shown is at least 4%. The 4% of the entire cell-free DNA in the maternal blood must actually be fetal DNA for more accuracy. If you want to do testing of genetic disorders, screening for genetic disorders other than trisomy 21, 18, and 13, then this quantity of cell-free DNA has to be more than 8%. So cell-free DNA testing depends on amount of fetal fraction that is present in the maternal blood. This is a very, very important thing for us. So any NIPT report that you see, they will report the amount of fetal fraction. The higher the fetal fraction, the more accurate that test is likely to be. So that's what we need to understand. Now, what are the indications? High risk by screening. So we can use NIPT as a secondary test. You do the first nuchal translucency, 3-beta HCG, PAPE, and then you select a subgroup of those patients and give NIPT to avoid invasive testing. So you can drastically avoid the number of CVS or amniotic that you can do. Second is, some people say, I want the best test to be given to me. I'm willing to pay for it. So it can be done as a primary test as a screening of choice. And advanced maternal age, 40-year-old woman, she comes, she said, don't waste my time. I want to know, tell me whether my baby is having Down syndrome or no. Then soft markers on ultrasound. Now, I'm talking about the first trimester. Okay. Now, it's a matter of debate. Say, when does the nuchal translucency of more than 3.5, let's say, should we do NIPT or should we do direct testing? So, generally, we say when the NT is more than 3.5, you go for direct testing. Don't go for another screening test because already this patient is at high risk. Now, a sibling with a pure trisomy 21, first child born trisomy 21, they want to know what it is. Or she's had, let's say, 2 or 3 miscarriages, and then she's had a baby with Down syndrome. Now she's very worried that an invasive procedure may may lead to a miscarriage again, but she also wants to know whether the baby has got Down syndrome or no. So in such cases, NIPT seems to be a good option. But NIPT cannot be done in some situations. We have to really understand this. Whenever there is a structural anomaly, no NIPT, right? Because when there's, that is why we say, even though NIPT can be done by 10 weeks, we say preferable to 12, do it after 12 weeks, after doing a detailed anatomical scan of the fetus. Second is vanishing twin. When there are two sacs, two gestation sacs, one twin FH is absent, never do NIPT because there will be a lot of confusion on where this DNA is coming from. Then you are looking at, there is a parental translocation. Mother has got a 13, 14, 21 translocation. Such patients are not suitable for NIPT. We'd rather go for direct testing. Now, when definitive testing is a choice, somebody comes and tells me, can you give me 100% guarantee that this baby does not have Down syndrome? Now, such patients with NIPT, I can only give 99.9%. That 0.1% I cannot give. Because if NIPT is positive, I still have to go for invasive testing. So, in such cases, I'll do that. Higher order gestation, triplets or more, no NIPT because you can't get a proper result. And of course, less than 10 weeks, we don't do NIPT. When you look at detection rates, we find for trisomy 21, it's 99.7 to 99.9. The false positive rate is 0.04 and the positive predictive value is 50%. This is the highest positive predictive value, because what do I mean by positive predictive value? When I say its positive predictive value is 50%, I just need to do 2 amniocentesis to find out 1 Down syndrome. In your combined testing, you have to do 25 amniocentesis to find out 1 Down syndrome, or 25 CBSs to find out 1 Down syndrome. So positive predictive value is very high, and that's why so it's called OAPR. Our odds of being affected with a positive result is 1 in 2. For trisomy 18, 13, and monosomy, the detection rate are slightly lesser, but still much better than your combined screening. So when you get a result of NIPT, you get 3 types of results. One is low risk, high risk, and then no call. When it's low risk, you just do routine follow-up, nothing is necessary. When it's high risk, you do CVS or amniocentesis, and with a no call, we might have to do a repeat test run. Considering it takes about 15 days for the results to come. Now some labs give it to you in about 7 to 10 days. And you might have to do a repeat test, or you go directly for amniocentesis. Once you have a NIPT positive, it is not an indication for termination of pregnancy. You have to do an invasive testing, because I said, when you do 2 amniocentesis, one will be Down syndrome, the other will be normal. So there's a chance of baby being normal, so don't do a direct termination of that. Now what about microdeletions? The prevalence of microdeletion, the population itself is quite low. The positive predictive value for NIPT for detection of microdeletions is low. It is not recommended as a screening for microdeletion and aneuploidies other than trisomy 21, 18, and 13 because of lack of sufficient validation. Lots of people are doing it, but it's still not fully validated yet. However, there is increasing evidence that this will be used in the future once, like say, for example, if there's 1 microdeletion, they need at least 1,000 to 2,000 such cases to be diagnosed before it can be, and validated after birth before it can be given as a proper testing. Now you can get false positive NIPT report when there is confined placental mosaicism, because what you are sampling is the trophoblast and not the fetus itself. Second is in vanishing twins, maternal mosaicism, aneuploidy, and copy number variations. The mother herself is a mosaic, let us say. Then you will have abnormal results. Maternal neoplasm. This is increasingly being diagnosed, and in the West, there's a false positive NIPT report. They are actually looking out for maternal neoplasms in some centers. Technical issues, suboptimal collection, and also prior organ transplant. So if she's had a renal transplant and she's pregnant, better not to go for an NIPT because you'll get a false positive result. You can also get a false negative NIPT. false negative NIPT to true fetal mosaicism. There is the fetus itself has got a mosaic pattern, then you may not get a proper result. Technical issues against suboptimal and also low fetal fraction. These are the cases where you get a false negative NIPT. Here's a typical NIPT report for chromosome 21. It says very low risk in this group. And then they've actually given for number of all the chromosomes completely. This particular result they have looked for all the chromosomes, and they've also said low risk. So there is a group called rare autosomal trisomies or RATs. There's a debate going on whether we should be using NIPT for identifying rare autosomal trisomy. But when I look at a rare autosomal trisomy, other than trisomy 21, 18 and 13, you know that 18 and 13 usually will have structural abnormalities, and other autosomal trisomies, many of them by natural process of selection, they will get aborted on their own. Some of them which are still present, they may have structural markers, and that's why doing an extremely good scan is very important before you go do and then try to get that. And any disorder, genetic disorder, we must have what we call as a phenotype-genotype correlation. We probably speak about it a little bit about later. So here's a patient who trisomy 21 greater than 1 in 20 risk score. So this is high risk. What we will do, we did a karyotype for this patient, and it turned out to be Down syndrome. Some people say, let's not go for karyotype, let's go for microarray, and there are some centers which switch over to microarray. We still believe in some basic stuff. When I'm looking for a structurally normal fetus, I know that it's screen positive for Down syndrome. I'll do a QFPCR or a karyotype to run down. If it is Down syndrome proved, then we do it. If it's a normal karyotype, we leave the baby as normal, because the higher the test you do, the higher the chance you'll pick up something. And many times, when you pick up something on a higher level genetic testing, we don't know what to do with that information. We don't know how to consult the patient. So better to keep things as simple as possible and then migrate towards higher testing when required. Now this baby has got a positive for XXY, and that's the karyotype was done, and you can see double X and Y. So this is also possible to do sex chromosome aneuploidy. Now we have already spoken about no call or test failures. When there's a no call, a decision has to be taken whether you are going to resample the patient or retest the same sample first, or resample the patient, or go for further invasive testing. And so this patient was resampled, and they said, "Thank you very much for choosing SOTA. We are sorry to inform you that the NIFTY test cannot be completed because of low fetal fraction. Low fetal fraction means fetal DNA is below cutoff of 3.5%. So in such cases, doing a repeat sample is not going to be of much value." Now, what about twins? Can we do NIPT in twins? The median fetal fraction in twins is about, in singleton is about 11.7%. In twins, it's lower at 8.7%. No result. In singletons in 1.7%. In twins, 5.6%. In other words, there are higher chances you'll get a no result when I do NIPT in twins as compared to singleton. IVF conception, obesity have a lower fetal fraction in that. And of course, when you get a result from a twin pregnancy, I don't know which baby is positive. Whether if it's a monochorionic twin, I can apply it for both. But if it's a dichorionic twin, I don't know which to do both, and I have to do sampling of both fetuses for me to find out. The detection rate is about 98.2%, still better than your first trimester combined screening for twins. So we may still do NIPT in twins, understanding higher no-call rate and slightly lower detection rate as compared to that. Now, what about soft markers? Once you have done NIPT, soft markers on ultrasound have no value. Once you have a low risk for cell-free DNA, you come to the second trimester, echogenic intramyotic focus, some nuchal fold thickness, all kinds of things are reported. Renal pelvic cases, these have absolutely no value at all, and in a low risk cell-free DNA, because you have applied an extremely powerful filter in the first trimester, and you have taken care of all the babies with Down syndrome would already be filtered, and what comes afterwards is a very filtered population. In this filtered population, these markers have no value at all. So no need to panic. One of the big advantages of doing NIPT the first trimester, don't worry about soft markers in the second trimester. Now, let's look at this 11 to 14 week scan. Now, this is NIPT. What more can we do in the 11 to 14 week scan? Now, 11 to 14 week scan is used for identifying the number and chorionicity, dating the pregnancy, aneuploid detection. We have already filtered with NIPT. If you have not done it, it's about 90%. Anomaly detection is close to 70%. And that's a major use of doing the first trimester targeted scan. Preeclampsia screening also can be done with an 80% detection rate. We are not able to move forward in preterm labor, so it's really not. By doing cervical length in the first trimester, we know it's not going to be of much value. So 11 to 14 week scan is literally the first decision-making milestone in pregnancy. There are some essential components. One of the beautiful things about ultrasound is you can push it to as much as you want. You can keep it at one level, or you can push it to the boundary of what is possible in that particular time. So essential components, if you want to see, crown rump length, head circumference, and a simple anatomical evaluation. This is all that's required for a routine first trimester scan. Then there are optional things we can do is abdominal circumference and femur length, and aneuploid screening, of course, NT biochemistry and additional bicam parameters, and extended first trimester scan. You add nasal bone, ductus venosus, tricuspid regurgitation, uterine artery Doppler, and intracranial lucency. All this is going to give you something more than what it is. But if you have done a first trimester NIPT, then your nasal bone, ductus venosus, tricuspid regurgitation does not have much value for aneuploid screening, but ductus venosus and tricuspid regurgitation have value for diagnosing cardiac abnormality. So that's why we need to do it. Even though you have done your first trimester screening, NIPT, you still have to do it for that. Now, one of the rock bottom things is getting the CRL right. Every person in this audience, I would recommend that once you see a report of a first trimester scan report, the first thing is don't read the report. Don't read the report. See the images. And when you see the images, you see a crown rump length picture which is like this, then you accept the report. If the CRL is not, if it's in any of these kind of images, then discard the report straight away, because anything else written in that report is going to be wrong. So this is the first filter, and it is you who have to audit and demand this quality from whoever is doing the ultrasound. And if you don't do it, then all kinds of things will happen. Decision making go wrong. A lot of wrong decisions are made just based on a wrong CRL. So that's something we have to interpret. The next, of course, is doing the nuchal translucency in the right way as recommended by the Fetal Medicine Foundation, where you have to zoom the image well and mid-sagittal view and all the others. We won't go into those details. But there are other markers. The other markers are absence of nasal bone, most difficult and the most controversial marker, I should say, because FMF itself has given up on the nasal bone. They don't put it on that website anymore. But in India, it is deeply entrenched, and if one person does not do nasal bone, I say, oh, you didn't do nasal bone. That's the whole thing is good. And if you do the nasal bone, you say absent nasal bone, patient thinks the nose itself is absent, and they want termination of pregnancy for it. There are several patients that termination happened because of absent nasal bone or report. So we don't use the term absent nasal bone. Please use the term unossified nasal bone. Nasal bone is there, but it is still not, calcium is not there. So it's a much better terminology as far as the patient is concerned. Then you have, of course, ductus venosus, and you have a forward flow, no reversal of A wave, and tricuspid regurgitation. But these to be done only if you are competent, certified, and have special software for interpretation. Right. Now collating the information. So you have all this information. Your final objectives is to inform the patient about the probability of a fetus affected with Down syndrome. As I said, if you have done an IPT, now disregard many of these things. Don't go into screening. Switch your entire focus on identifying anomalies in the baby. Once you have done NIPT, you go for anomaly detection in the baby. If you have not done NIPT, then you go, you identify the a priori probability, then you identify markers on ultrasound using biochemistry, modify the probability, and decide the cutoff. Once the cutoff is more than higher than 1 in 250, you go for direct invasive testing, and you discuss with the patient about it. So the major difference is before or after NIPT, where your focus is going to be. Your focus is going to be on anatomical evaluation of the fetus. Right. So let us now, you have two options here. One is NIPT, that is the combined testing. How can we effectively use that? NIPT we can't do in everybody because it is still too expensive. So what we do is first line by combined testing. Then you look at the result. Then you can look at one and two ways. You can keep a cutoff of 1 in 50 or even 1 in 100, okay? Or some people say 1 in 10, but you can keep a cutoff of 1 in 100, let us say. Risk more than 1 in 100, go direct invasive testing. Less than 1 in 1,000, don't do anything at all. Go for nothing else, go for second trimester targeted scan. Now, when there's a risk between 1 in 100 and 101 to 1 in 1,000, it is called as intermediate risk. It is this intermediate risk group you give the cell-free DNA. If it is screened positive with cell-free DNA, do invasive testing. If it is screened negative, you do nothing else. If it is no result, then you go back to the combined test result, take a decision on what you want to do. So it's a very simple way of effectively using cell-free DNA, reducing the cost to the patient, and also reducing the number of invasive procedures that you need to do. This is an accepted method. Now, when you in the first trimester, should we do biochemistry? This is a big question because there are two aspects here. One is Down syndrome, but in the first trimester, the major advantage of screening is screening for preeclampsia. And we should say that more than the incidence of Down syndrome, there is preeclampsia. Unfortunately, we keep it at a very, say, if she develops hypertension, then I will deal it with at that time. We are not saying, I want to prevent preeclampsia. I want to reduce the morbidity of preeclampsia. We are not talking about it in the first trimester, and I think it's important that we start talking about it in that way. So when not to do biochemistry, if NT is greater than 3.5 mm and it is correctly done, you go for direct testing, or if there are anomalies detected, no screening, no biochemical screening, please do. And if it also, I would not have done an NIPT also in the first place. I would have gone straight away first. Second is inappropriate NT. It is NT taken in a very bad manner like this. Don't use double marker. The word double marker is a terrible thing to use because it's very liberally used. So if you don't have anything, okay, let me at least do the double marker. It's the worst test to do. The sensitivity is less than 60%, and you will get into all kinds of trouble just by looking at double marker. You're not reassuring the patient in any way at all. So don't rely only on double marker alone. You can do first trimester quadruple screen because along with pre-beta-G PAP-A, you can have you can add AFP and LGF, and you will get a quadruple screening, which has got the same sensitivity as your second trimester quadruple screening. But you can do it much earlier in the first trimester, around 80% pickup rate. So if you don't have proper MT, go for 4 biochemical markers, not those 2 biochemical markers. Then first trimester preeclampsia prediction. I don't want to talk about preeclampsia, but certainly it's an important thing we need to consider. And what do you do for preeclampsia? First is the aspirate trial gave us a lot of information, and that is what we use. And a trial like aspirate trial can never ever be conducted anymore because the standard of care, they have shown very clearly that aspirin modifies preeclampsia. Aspirin is useful, and that intervention is already decided. No disputes on that as so far. So history, blood pressure, maternal blood pressure or mean arterial pressure from both sides. Then maternal demographic factors, uterine artery PI, and we take the mean PI of both uterine arteries and PAPE and PLGF. Now they say either PAPE or PLGF both can be used, can do that. But when you do that, the detection rate for preterm preeclampsia is over 90%. So it's a very, very good test to do, but done very meticulously and very carefully, that the way technique of uterine artery Doppler also has to be followed correctly. So once you give aspirin, the dose-dependent benefits are observed for more than 100 milligram per day. So the treatment is 150 milligram aspirin taken at bedtime from 12 weeks to 36 weeks. Reduce the risk of preterm preeclampsia by about 60%. And if the compliance is greater than 90%, the reduction in this may be up to 75%, which is very, very, very good. So aspirin after 16 weeks is no benefit. Supposing you've done the second trimester uterine artery Doppler and you find high resistance flow, okay, now let me start on aspirin now. It's absolutely of no value. So that also has been proven. Now there are some don'ts of screening. Okay, one is, as I said, NT more than 3.5. No biochemical screening for triplets or more. No screening if CRL or NT is not right. No double marker alone in the first trimester, as I said. No screening within 1 week of taking injection HCG. And no screening if donor date of birth is unknown in ART pregnancy. Extremely important. With the number of ART pregnancies increasing, and if it's a donor program, the donor's date of birth must be recorded. It's not if say she's a 25-year-old, she's a 26-year-old. It's of no use that way. You need to get the donor date of birth, because the Down syndrome screening a priori risk is calculated for the donor date of birth. And no screening if multiple markers are, supposing you say NT is 3.2 and there is a tricuspid regurgitation, there is a wave reversal in ductus venosus. No point in screening. Go for direct testing. Most likely the baby will be Down syndrome. Or there's absent nasal bone. There are 2 or 3 markers already present. Go for direct testing instead of screening. So next is increased NT beyond Down syndrome. So now there's an increased NT. We are looking for Down syndrome, but we should be looking beyond Down syndrome, because it could be trisomy 13, 18 or other aneuploidies also. It could develop into cystic hygroma over a period of time, or there could be skeletal dysplasia, or congenital diaphragmatic hernia, or cardiac anomalies. So a number of other conditions, more than 65 conditions have been associated with increased NT. And in other words, once there's increased NT and I've ruled out Down syndrome, I've just ruled out the most common cause of increased NT. There are other things, my responsibility does not stop there. And that's why increasingly for increased NT, instead of karyotyping, go for microtyping. Now there, your yield is a little bit more than karyotyping to do. So here are, once you see anomalies, there are some classical features of the first trimester fetus, which helps you to diagnose trisomies 13 and 18. So here you can see polydactyly and holoprosencephaly, which turned out to be trisomy 13. And here you can have a cystic hygroma with a pleural effusion, which turned out to be Turner syndrome. And you have a tricuspid regurgitation, absent nasal bone here, which baby had a double trisomy 7 and trisomy 21 in the same baby. So anything can happen. All it tells us, if you have these markers, go for further investigation. But important thing is no termination of pregnancy without a karyotype. Not only for this pregnancy, you are going to counsel her for subsequent pregnancy, and if you see a translocation, for example, then you might have to investigate the parents. Now, increased nuchal translucency and cardiac defects are very, very well known. Right? As the NT increases, the risk for cardiac defect also increases. When the NT is more than 5.5, you can see there's a 12.5% increase in the presence of cardiac defects. So I think it's very, very important that we look for that. So any NT more than 3.5 or NT above the 99th centile for the fetal gestation, detailed fetal echocardiogram is essential. It should form as part of your protocol. Now, reversal of A wave in the ductus venosus, as you can see here, shows when there is no NT status given, the sensitivity of detection of cardiac anomalies is 50%. In the presence of an increased NT and a reversal of A-wave ductal stenosis, the detection rate for the sensitivity of diagnosing anomalies is 83%. So I have an NT of 4. I also have a DB reversal. There's a very high chance this baby will have a cardiac defect. So we need to look for that. And if the NT is normal, it's only 19%. So this combination of increased NT and reversal is a very powerful combination as a screening test for cardiac disease. So here you can see a pathology where writing of the aorta. Okay. Now this I think has already been shown to you. NT thickness and adverse outcomes. Higher the NT, obviously number of cases alive and well will be lower and lower as the NT increases. But again, once you do a detailed examination, you do NT PCR, increase NT PCR, no Down syndrome. Then you do microarray. Microarray is normal. Can we stop there? Unfortunately, no. If that thing is there, you will have to go for the next level, which would be your exome sequencing. So you go step by step, increase, keep on pushing till you get an answer. But at which point am I going to tell the patient, your baby is normal? That's a very, very difficult point to reach. Where you say, at the present point of time, whatever we can investigate, we have investigated for the most common causes. It is not there. So we expect the baby to be normal. And what will happen is anything that goes wrong with the baby will be attributed to this later on, even though there is no correlation between what's happening here. So supposing the baby is born and baby has got deafness, and they'll say, "Oh, you never told me that increased NT is equal to deafness." They're going to do that, but we are not going to be worried about that. Most common. We are here to diagnose the most common problems, not the rare issues which could be there. Then we come to the first trimester anatomical scan. There is the anatomical checklist which we use is called as the rule of 2. Simple rule of 2 that every part of the baby just look for 2 things alone. And you document it. And once you document it, like face, for example, orbit and premaxillary triangle, the spine, the entire spine and the interconducency, heart inflows and arches, abdomen, stomach, and bladder. These things will help you to quickly do an anatomical screening for the baby. If any of this there's suspicion, you go for detailed examination. So here you can see the head, the spine. Here you can see the mid-sagittal view with the interconducency. You can see the arch view and also the four-chamber view. So that's the inflow. And then you just move your probe, you see the outflow also there. And that's a very, very good screening method for that. So stomach and bladder, upper limbs, lower limbs, and all this you can do that. Now just to give anomalies which may present, anencephaly, holoprosencephaly, spina bifida, close to 90% detection rate in the first trimester, and anencephaly and holoprosencephaly, 100% detection rate in the first trimester. I'm talking about A-lobar holoprosencephaly. Now, sometimes open spina bifida can be missed in the first trimester because of fetal position. Interestingly, majority of the fetuses which you screen, the spine will be posterior in the first trimester because the baby is lying down in that posture. And when you want to have a good look at the spine, you want the baby to turn around and you want to see the back of the baby. And once you're able to see the back, then the detection rate of spina bifida is better. But we use these indirect signs, especially intracranial lucency, to do that. Now, the other important thing is, any anomaly that is obvious, say, oh, I've diagnosed spina bifida. Spina bifida not compatible, so please terminate pregnancy and forget about it. Next time she comes, again spina bifida. But I put her on folic acid. So take folic acid, pre-conception, she done that and still come. So you say, okay, next time nothing will happen. This is not something very rare. Again, she has the same problem. Then what do? That means you have not done the diagnosis right. Obviously, this is not spina bifida. This is something more than that. So here's a patient, 13 weeks, referred. You can see the lemon sign and spina bifida very well seen. And when she was, the baby was delivered, we did an X-ray and found it was actually spondylothoracic dysplasia, Charcot-Lewin syndrome. And Charcot-Lewin syndrome has got a 25% recurrence chance. Now, folic acid is not going to help in her. So, it is important that even if you see a simple anomaly, which obvious anomaly, this baby must be examined postnatally. Yeah, take an X-ray of the baby, and you have to ask somebody to examine the baby in detail. Then we can see all the abdominal wall defects. Again, very high detection rate for abdominal wall defects, omphalocele, gastroskeletal, body stock anomaly, and also presence of amniotic bands. And the bladder, when you see a enlarged bladder, which is called megacystis, and we know that when the bladder is between 7 and 15 millimeters, we have to do a karyotype because can be associated with Down syndrome. But many of the big bladders in the first trimester can resolve in the second trimester. So let's not rush and do anything rash about termination of pregnancy just for an increased bladder size. We will wait for the second trimester. We'll call her for an early target scan. Instead of taking her at 20 weeks, we'll call her at 16 weeks to see how this is evolving. Then, of course, facial abnormalities, cleft lip and palate. Sometimes clefts can be, especially soft tissue, that is because soft tissue is not well formed in the first trimester. Isolated cleft lip may not be diagnosed very well, and posterior palate may also not be diagnosed at this stage. So you might have to wait for the second trimester to get a diagnosis of this. But limb anomalies, first trimester is the best time to diagnose limb anomalies because all four limbs can be seen extremely well, and you can also, I think my time is up there. So extremely well, and this is something which we can easily make a diagnosis, and we should not miss the opportunity of doing that. Cardiac anomalies. Nearly about 60% of cardiac anomalies, severe cardiac anomalies, can be diagnosed in the first trimester. Could be equal to identify cycles problems, hypoplastic left heart, hypoplastic right heart, and also atrioventricular septal defect. All this can be diagnosed first trimester. The opportunity is once you diagnose, some of them we have to wait till it evolves to reconfirm at 16 to 18 weeks for before we can talk to the patient in detail. We talk about it when we look at the cardiac section. So here you can see in a round series of close to about more than 52,000 patients, there's a 68% detection rate of anomalies in the first trimester. And when we did an ultrasound to autopsy correlation, 98.4% correlation between ultrasound and autopsy in diagnosis. So that means when we predict, and if you are good at your work, you can predict with a high degree of accuracy. So when you counsel the patient, you're actually counseling them with information which you truly believe is true and is likely to be true. And I think that's very important. Right. So I'll close down with this, the value of a detailed first time. This is a paper, because it was given a title, I went and said, has anybody really worked on this? And I found American Journal of O&G, 2023 June. That means it is hot off the press. It has still not been printed. It is the online version. So I didn't have the access to the full article. So I wrote to somebody in the US and they sent me the full article. And I read what exactly they did was, they said, what are the additional findings identified to first trimester ultrasound that would otherwise have been missed if non-invasive prenatal testing was used alone as a first trimester screening method. And what they said was 2,158 patients with 2,216 fetuses, NIPT high risk. There were 65 patients, that is 3%, were NIPT high risk. NIPT low risk was 97%. And in that low risk category, 5.4% had abnormal ultrasound. So this is a group where they do NIPT for everybody. Okay. And they do it very early at 10 weeks before doing an anatomical scan. So they said, even NIPT, so the incorporation of first time ultrasound screening identified 116 additional features at 5.4% that require further follow-up and surveillance than non-invasive prenatal testing alone would have identified. So NIPT alone is not the answer. Structural and anatomical scan is as important. NIPT is looking only for some specific abnormality, specific trisomy 21. So I'll stop here. Thank you very much.
Sir, how we can do pre-eclampsia screening in a low resource setting?
Low resource setting. So in a low resource setting, maternal history. Yes, there is a previous history of preeclampsia, 6-fold increase in the risk already. Plus uterine artery Doppler, which you can do anyway. You have ultrasound, that will filter some cases through that. But if you want really predict, give a number to the risk, then the risk prediction algorithm unfortunately take care of all these things. If you're saying, okay, I'm happy with 2 parameters, previous history of preeclampsia and the uterine artery Doppler, start on aspirin. That's the easiest way you can do. But if you're doing Down syndrome screening, then PAPA is already there for you. So you just have to ask the lab to say, give me preeclampsia risk also. But you do the maternal blood pressure. And that's another important. Maternal blood pressure is something which you can do. The only thing about this is, today we have online tools which are available. So all these parameters, you can put it online, get your
Even lateral length is say 10 millimeter with normal NT.
Yes.
Then how
Yeah.
how
So it's a thing. So I have not been very fond of going and doing invasive testing for a bladder alone of 10 millimeter. I'll wait for it to evolve in the second trimester. I'll wait for it to evolve in the second trimester and then I'll take a call on that. Isolated bladder, we don't go and do invasive testing.
In case of confined placental mosaicism, there is chromosomal composition of placenta and fetus both are different. So in this case, whenever we go for NIPT or we go for CVS, both are going to give false positive results. So wherever these things are positive, in which case should we wait for a second trimester for till the stage of amniocentesis, or is it
I think it's an extremely good question because the NIPT is nothing but placental trophoblastic cells only. So generally what has been said is, if the NIPT shows clear trisomy 21 risk, and if you do a CVS and it's pure trisomy 21, then it's unlikely, it's likely that it represents the fetus. There are cases of confined placental mosaicism. So in the ideal scenario, go for amniocentesis, which is a better thing to do that. But in scenarios where, so for example, with XXY, when the risk for NIPT comes as XXY, I'd rather do an amniocentesis than a CVS. But your classical, most common trisomy, we have recently had a patient, trisomy 13 positive, okay, and the fetus is structurally absolutely normal. Then such cases, I will not do a CVS. I'd rather go for amniocentesis rather than CVS to clear this. So you have to take a call on that. Ideally, amnio is better than CVS.
Thank you so much, sir, for such a wonderful session and teaching us in such a simplified way. I would request our chairpersons to please hand over the memento and a certificate of appreciation to Professor S. Suresh, sir.
Thank you, sir. Now I would like to invite our distinguished faculty, Dr. Mayank Chaudhary. He is a fetal physician in Mayflower Women's Hospital. He trained at Mediscan, Chennai, and he is a top winner of cow at fetusdeck.net constantly for 6 years, 2013, 2015, 2016, 2017, 2022 and 2021. And his special interest in twins, fetal growth disorder, first trimester fetal disorder and fetal echo. And his center is recognized as basic and advanced training for antenatal scan. He conducted many workshops for basic scan and fetal echo and color Doppler. Also, he is doing fetal intervention, fetoscopic laser surgery, and has his clinical interest in clinical genetics and dysmorphology. I welcome you on the dais, Dr. Mayank Chaudhary, sir. And I also invite our chairperson, Dr. Bhadarka, sir, Dr. Pannaben Rudani, and Dr. Ashok Hadia, sir. I think Dr. Bhadarka, sir, is not there. Then I invite Dr. Bhavik Khatri, Dr. Ashok Hadia, sir, as is.
Thank you for kind word of introduction. Good morning to all, and special thanks to all who are instrumental in organizing this meet, including all who are attending. I am very much thankful to Dr. Punit Khatri. We are together in UG and PG. Dr. Bhavik Khatri, Dr. Hirani, and Dr. Mewada. There are many familiar faces here. I am going to say something about fetal intestinal obstruction. And key finding in fetal intestinal obstruction is a intestinal dilatation, ascites, and there are signs of peritoneal calcification. And if you want to remember a few figures, then for a descending colon, remember 7, 14, 21, and for rectum, remember 7 and 14. 7 for a mid trimester and 14 and 21 for a late trimester. There was a complex situation when we are organizing this conference. We know the terrain and travel from Ahmedabad to Bhuj will take approximately 6 hours. And we released our brochure. At the same time, one more brochure was released near Chennai. Sir was student at Chengalpattu Medical College, and there was a workshop on Saturday. They also released the first announcement, and they started registration there. Now, what to do? How to plan this intense travel, this hectic travel? So we requested sir from our heart that please do something, please have a solution with this, because we have also registered a lot of delegates, and sir was quite humble to accept our visit, and he shifted the program from Saturday to Friday. They again announced, they did second announcement, they again started registration. So please have a round of applause for sir. His schedule for just for Kutch. Sir, there is one famous word regarding this geography, that in Gujarat there are specific area for specific weather. Like for winter, this area is good. For summer, this area is good. But for Kutch, it is called Kutch is ever for 12 months. We call that Kachado Bare Mas. Every time, whenever you come in Kutch, there is something happening and interesting things are going on. And this is since long. Regards from Mayflower Hospital and my team. as everybody is telling that when you do your scan, you start with a survey, and survey will give a lot of information. And when in your survey scan, if you find that the thing is remarkable in fetal abdomen, indirectly it is considered as a normal. And when there are intestinal lesions, usually the association of aneuploidy is very less in those groups, except when there is another system involvement. We indirectly see fetal abdomen when we are doing a CRN scan. You can see this echogenic area is a fetal bowel, and if we do not notice anything there, it is considered as a normal. As per ISO guideline, in abdomen we have to see two cystic shadow. One is stomach and bladder, and bladder and stomach and the heart will be on the same side. In a mid abdomen, we have to see the kidney, which is better seen after 65 CRN. You can put a Doppler to locate the kidney. In lower abdomen, you have to see the bladder and paravesical artery. And here you can see here, this is a bowel, and echogenicity of bowel is slightly more than liver. This is liver, or liver is slightly hypoechogenic than bowel. And lung and bowel echogenicity is almost the same. And when you use a high frequency probe, it will look more echogenic. And we have to document umbilical cord insertion. Again, at that point of time, indirectly we are going to see the intestine here and intestine here also. If there is a cord cyst, isolated cord cyst is not a big finding. And you can put a Doppler to see two umbilical artery. So now let us go through the bowel appearance throughout the gestation. In the first trimester, in this view, you can, if you can see here, this is a bowel, this is a liver which is slightly hypoechogenic, and this is a lung. Here, this is bowel and liver, and this is a lung. In cord insertion section also, you can see the bowel. In second trimester, if you are using high frequency probe, there will be an artifact of echogenic bowel. So you have to be aware of that. And if you are able to see few dilated intestinal loop up to 3 loop, and if it is less than 7 millimeter or just 7 millimeter, and the length of that loop is just 50 millimeter, it's better to repeat a scan. There is a high chance that it can be a transient event in a second trimester of pregnancy. In late second trimester, you will be able to see gallbladder also, and sometimes meconium filled bowel also. If it is seen, this is rectum, and if it is in just up to the level of pelvic bone or just higher than that, then it can be considered as a normal. And in late third trimester, you can see many times the hypoechoic splenic flexure and hepatic flexure will be seen. Again, that is a normal finding. So these are the nomograms for a descending colon and a rectum. As I told you, in mid trimester 7 mm, in late mid trimester 14 mm, and in third trimester 20 mm for a 21 mm for a descending colon, and for a rectum it is 7 mm in a mid trimester, that is upper limit, and in late trimester it is a 14 mm. So 7, 14, 21, you have to remember this, and whenever there is a doubt, better to refer this nomogram. Now, how to diagnose echogenic bowel? Whenever you see the echogenic bowel, the first and foremost thing you have to do off harmonic. Then you have to do gain minus whatever you are doing, that minus 15 gain. Suppose you are on 21 gain, then you have to go minus 15 gain at least, and you have to select the lowest possible frequency probe, and then you have to compare that echogenicity with adjacent bone like a spine or a pelvic bone, like that. And if it is as echogenic as that bone, then only consider. So if you do this maneuver, then almost 50% of so-called echogenic bowel will be filtered out. And when there is an abnormal and dilated intestinal bowel, the loops will be more than 3, the length will be more than 50 millimeter, and dilatation will be more than 7 mm. You can see here there are 1, 2, 3, 4 loops, and here there are multiple lobes. So if appearance is like this, then start suspecting a bowel obstruction. Paresthesis can be very well seen after 17 weeks of gestation, sometimes at 12 weeks also. And please remember, the more proximal obstruction or more proximal the pathology, the polyhydramnios will be early. When there is an oral obstruction, polyhydramnios will be around 20 weeks. When there is a esophageal atresia obstruction, around 22 weeks. Duodenal atresia, around 24 weeks. Jejunal, around 25-26 weeks. Ileal atresia, there may not be a polyhydramnios. So more severe obstruction, more early will be polyhydramnios. And when there is a polyhydramnios, there is a possibility of GI pathology in 14% of case. And today we are going to talk regarding just intestinal obstruction. And these are the list of disorder, GI disorder, where there is a good outcome and not a good outcome. And you can see here bowel perforation and bowel obstruction comes in a good outcome. Almost near 90% of case, the outcome will be good if it is isolated. This is a case, AFI 37 centimeter at around 29 weeks, and you can see this double bubble. Another bubble is near stomach, and communication is established between stomach and that duodenum. You can see this communication very well. This is a video clip for that. And as there was a gross polyhydramnios 37 centimeter AFI, so we do MU reduction for dragging the pregnancy in near term. That amniocentesis result was a normal. And hallmark finding of pathological duodenal atresia, you have to establish the communication between these two cap, and there should be a polyhydramnios. And this hallmark finding may not be seen just after vomiting, or if there is a leaking, polyhydramnios will not be seen. In case of multiple pregnancy also sometimes it is not seen. But remember, if there is a duodenal atresia with endocardial cushion defect, there are high chance of trisomy 21. This parent was quite motivated. We did a MU reduction. KT was normal. Baby delivered at term, and the next day the laparoscopy was done, and it was not a duodenal atresia, but it was actually Ladd's band, which was obstructing second part of duodenum, and it was exactly mimicking and creating the artifact of a double bubble sign. So things may be like this also. Even annular pancreas also can create such type of artifact. And itself, duodenal atresia, when karyotype is normal, it is a operable condition. And if parents are in search of hope, you should give hope to the parent. This baby is 10 years and doing well. And many times due to stomach peristalsis also, you will be able to see double bubble sign. And just wait for some time, and stomach shape will be normal in such type of case, and don't overdiagnose double bubble sign. And dilated gallbladder also, it is very near to stomach, and many times can mimic like a double bubble. But in this case, you will not able to establish communication between them, duodenum and stomach and gallbladder, and Lycan will be normal in majority of case. Here you can see here, this is a gallbladder and this is stomach. The size of gallbladder is bigger than size of stomach. So please be careful. And whenever there is a dilated cystic shadow, you have to put a Doppler and rule out that either that is a vascular lesion or not. So gallbladder will not pick up a color. So this thing you have to remember. Another case, this case was referred for echogenic mass near kidney, and you can see the kidney is here, and this echogenic mass you can see here in anteroabdomen. So when it is very well in anteroabdomen, the renal mass is ruled out. Kidney is a retroperitoneal structure. There was a mild polygonus. This baby, the growth, doctor, everything was normal. The rest of the anatomy was normal. We put a provisional diagnosis of pseudomyconium cyst and tell patient that prognosis will be good in your case. And this baby was delivered at term, and the baby was completely asymptomatic. But there was additional finding of hypospadias and left side undescended testes that we could not pick up in a second trimester and third trimester. And again, it cannot be picked up, and we are not looking for that also. This thing also we have to remember. Baby was asymptomatic, but to save the left side of a testis endoscopy was done, and that pseudomeconium cyst was removed. And maybe these are my early practice stage. Baby is now 15-year-old and doing well, going in school and listening to girls. Another case, this was referred for second opinion with a finding of bilateral effusion and ascites. By the time patient reached us, the ascites very well subside and the bilateral pleural effusion become unilateral pleural effusion. The additional finding was maternal hepatitis B, and before 20 days there was a high bilirubin and all those things. And now all those reports became normal. By the time patient comes, the thing was resolving, and wherever the things is resolving, and the growth, Doppler, and the lichen is normal, the prognosis is usually good in that case. And due to telltale of intestinal perforation, the pseudomeconium cyst developed in this baby. You can see here, this is peritoneal calcification sign, and one side pleural diffusion. And we did a regular follow-up in this case, and outcome is good. The baby is at present 12-year-old and doing well. This is a pseudomeconium cyst in the same baby. Unfortunately, there was no complaint. Another case, directly referred at 37 weeks with a gross ascites, gross fetal ascites, and AFI was 23 centimeters to mitochondrial. So at 37 weeks, what to do? But at the time of scan, there was finding that the diaphragm was quite raised. So that input was given to the neonatologist team that if there is a respiratory depression or difficulty, then just put a needle and drain ascitic fluid, and the things will be better. The same thing happened. BD was delivered, and there was a respiratory depression. Put a needle and 500 ml of ascites fluid was drained, and then the aspiration became normal. It was a removal of ascites. It was not a removal of pathology. Okay, so patient was in a NICU for a 1 day, 2 day, and second day we counseled that this will require surgery, as there is a perforation and this ascites is due to that perforation. The patient was reluctant for surgery because referring consultant counseled very negatively that your case is a hopeless case. So patient did not agree for surgery. On day 3, again the situation was same. Then we told the patient, we will not this baby die in our hospital. Take this baby to your home or another hospital. So after such type of counseling, the patient was ready. અહીંયા અમે ચૂપચાપ જતા રહીશું, બરાબર? પણ ખબર છે કે જ્યારે ડાયટ થાય ત્યારે ચૂપચાપ નથી જતા, મીડિયા સાથે જ આવતા હોય છે. So we insist them for surgery, and during surgery, just there was a meconium plug, and that meconium plug was removed, and ileoileal anastomosis was done, and the baby is fine. You can see here, 10-year-old, this baby is ready for Republic Day function. Another case, you can see here, dilated bowel lobes, but here there are just 3 in number, and between nearby gallbladder and nearby umbilical vein, there is the creating artifact of 4th and 5th loop of dilated bowel. So when patient was referred with a diagnosis of multiple intestinal loop dilatation, we saw that is just 3 loop. The length was just 15 millimeter. So we asked for a follow-up examination. And in follow-up examination, this thing completely resolved, and this baby is doing fine, and this mother is so much happy that every birthday they are sending one picture to me, because again she was counseled that we are going to this baby will not able to eat, we will not terminate this pregnancy. Another case referred with a large cyst in a fetal abdomen with a finding of fetal ascites and abdominal cyst, and you can see here ascites, large cyst, and some echogenic area that is a meconium ball or meconium at that area, and this was referred around 27 week of pregnancy, and this was the isolated finding. The growth, the liquor, and everything was normal. We tell the parent that yes, there is a pathology, and pathology is significant, but we have a solution of this pathology postnatally. And if you are ready to face a fetal surgery in a postnatal period, yes, you can continue this pregnancy. And we refer this patient to pediatric surgeon and neonatologist both, and then patient agree for the follow-up examination and to continue the pregnancy. And at the time of 35 weeks, that ascites is completely resolved, that cyst resolved, and you can see this pseudomeconium cyst, that's telltale of a peritoneal perforation, and there was a mild ascites. And there was one additional finding which was expected. You can see the to and fro movement of bowel content, and in doctor also you can see red and blue signal at the same level. So this is a sign of intestinal obstruction. Baby was delivered. There was motivated parent, and baby was operated on day 2, and there was meconium all over the bowel and liver. Anastomosis was done, and jejunum and large bowel was normal. There was good residual amount of intestine, and you can see the piece on the face of this baby after surgery, and this baby is also reaching the 4th birthday. Another case, almost with the same finding, large ascites and cyst before at 24 week of gestation. This is another case which is HbSSG positive. Okay, so when we open the literature in one corner, apart from the torch infection, we found this cause HbSSG as a cause of intestinal perforation, and which is more common than torch in our country. So whenever you see such type of patient, after torch do HbSSG report also, and we are routinely doing that in pregnancy, but after this finding, please do that. And SGPT, maternal SGPT was quite high, bilirubin was 10, and referred from government hospital. After a few days, this patient underwent in a preterm labor, and we lost this baby. This baby could not be saved. This is a first trimester. We will say what we can see in a first trimester. As I told you, if nothing is noticed unremarkable, it is considered as a normal finding. And then there is another moment where we can see the fetal bowel at the time of ductus. Also, we can see the fetal bowel in between in this area. And if it is unremarkable, we consider that as a normal. Same patient came for a second trimester examination, and we observe one bowel dilatation, rectum dilatation, and it was going up to the splenic flexure, right up to the splenic flexure. Okay, so we asked, did you underwent the first trimester scan? She told yes. Who did? She told yes, sir, you did. You can see it was low risk. First trimester was low risk, and bowel was dilatation was more than 7 millimeter in diameter. For mid gestation, that is more. So we counsel them there is a chance of bowel obstruction, and the target sign was not seen. This is a normal target sign. Left side lower image. This is normal target sign, and which is not seen. So in such type of reason, the two you have to cross check two things. One is perineum is well defined or not, and you have to see the target sign in this case. And it was absent. So we tell patient that there is a chance of high anorectal atresia in your case. So we give bad news. The patient went for window shopping and lost for a follow-up. Went for a follow-up at another place. When we call the patient did not like us and tell them please do not call us. So some type of experience also we will have, because we have given bad news. They don't like us. This happened many times. Another case, you can see the gross dilatation of stomach and second part of duodenum along with the jejunum, and you can see debris material inside the fetal stomach. Again, you can see the telltale of obstruction. You can see the to and fro movement of and Doppler signal red and blue at the same level. So this was a case of intestinal obstruction, and baby stabilized, and surgery was not done on day 3, and there was uneventful postnatal period. So if the series is big and time is less, so just to summarize all this case, if you can see that the outcome was good in a few cases and not good in a 1 or 2 cases. and there was a common pattern. When there was a good and there was a bad, there was a common pattern. You can see good, no associated finding at term, no associated finding at term. And neonatal date when there was a preterm vaginal delivery and there was a associated finding. There was another case where there was a dichromatic pregnancy. One baby was normal, another baby was with a intestinal bowel obstruction, and the two twins that delivered preterm and around 28-29 weeks, and one baby normal, lived normally, and another baby there was a necrotizing enterocolitis, and that baby died. So we derive at a common pattern when we have to tell that there is a good outcome or a bad outcome. When the growth is normal, normal and near normal liker, normal Doppler, no associated finding, resolving of finding, and if you deliver near a term in motivated parent, all patient the outcome is good. So don't be panic. Intestinal obstruction, deflagging ascites is not an indication of preterm delivery. Okay? Oh, ascites now ascites is increasing, the bowel dilatation is increasing. To be terminated at bowel में to damage हो चुका है. No, don't do it like that. Track that pregnancy near term, counsel the parent, and management at term is more easy. Anesthesia and all those is less as compared to preterm. Another thing, when the patient is referred, now everybody know how to diagnose. Now from Monday morning also you will be able to know, and you will send the patient that Dr. Mayank, we have diagnosed bowel obstruction. Now you have to tell it is jejunal or ileal. Because you are senior, you are expert, you have to tell them. But please remember, the level of insult cannot be judged accurately antenatally by scan. Obstruction can be diagnosed. The level of obstruction, no. But there are some hints. Okay. If there is a marked dilation, multiple loop, left side areas, abdomen, then the chances of jejunum is more. The stomach is large, the jejunum is more. Peritoneal calcification is frequent in both. Ascites is rare in jejunal obstruction, but in ileal obstruction, it is a frequent, and associated anomaly and polyarteriomas are frequent in both. So there are various type of intestinal obstruction and intestinal atresia as per postnatal classification. We will not go in that detail, but as a general guideline, when you are diagnosing a small bowel obstruction, the prevalence is 1 in 5,000. If isolated, there is no increased risk of recurrence because going for termination is easier, and then again conceiving is very much easier. So patient will tell, "Sahib, hamari chukka." Okay, so you can reassure, right? The common scan finding, as I showed in case, is dilated bowel, distended fetal abdomen, ascites, cyst, pseudocyst, meconium peritonitis, echogenic area over peritoneal surface, liver diaphragm, and polyhydramnios if obstruction is proximal. Incidence of chromosomal abnormality and genetic syndrome is not increased in this group of disorder, and there are chance of other bowel anomaly like malrotation, meconium, gastroschisis, lubrication cyst, and 10% risk of cystic fibrosis in case of meconium peritonitis. But first you will investigate parent and then you will investigate in baby. You will not directly put a needle and start doing investigation. Detailed scan is must, and as a workup of polyhydramnios, we have to go for MCA, PSP, TORCH, or OSB19 infection test. And prenatal diagnosis is only suggested if background risk is high or the parent or carrier for cystic fibrosis, then only. Follow up every 2 to 3 weeks, monitor growth, assess a amniotic fluid volume, and delivery at term. And a neonatologist and pediatric surgeon should be in a loop along with you, because baby deliver થયા પછી ક્યાં જવું એને ક્લિયર થોટ એના માઇન્ડમાં હોવા જોઈએ, બ્લાઇન્ડ ના હોવા નહીં તો ઇમેજિનેશન ચાલુ કરશે. Because due to in information of our imaging science, we will imaging a lot, so we have to give him clarity. The prognosis is good if there is no associated finding, and when baby is born after 32 weeks of gestation and after resection the residual bowel segment is good, then survival rate is more than 95%, and when there is a short gut syndrome, survival is poor in that condition. Meconium peritonitis is many times coexist with this. Prevalence 1 in 3000. If isolated, there is no increased risk of recurrence. Common scan finding are intra-abdominal hyperechogenic area, echogenic area over peritoneal surface, liver diaphragm, local sterile chemical peritonitis due to perforation, distended fetal abdomen, ascites, and the almost same investigation as we do in case of intestinal obstruction. Case, and again, prenatal diagnosis suggests only for cystic fibrosis if both parent are carrier or background risk is high. Follow up every 4 weeks. There's no need of intense follow up as compared to bowel obstruction, and delivery at term, keeping a loop with pediatrician and a neonatal surgeon with them. In case of simple peritonitis, the outcome is good. In case of complex peritonitis, when there is abnormal growth like a Doppler other system involvement, and when residual bowel length is less, the prognosis is poor. So, what is the pathophysiology that lead to this bowel perforation? There is a mechanical obstruction due to atresia and stenosis, then there is a plug formation, perforation. There is infection, vasculitis, ischemia, sloughing of that intestinal part, and then perforation. There is inflammation due to various reasons that will lead to fibrosis, then again a plug formation, perforation. The inflammation due to various reasons, it can lead to fibrosis or it can lead to edema also. And there is a giveaway of that intestine and there is a perforation. There is a meconium ileus due to various conditions, stasis and plug formation, and there is a perforation. The accuracy of detection of intestinal obstruction, as I told you, is very poor except duodenal atresia. Okay, so duodenal atresia, yes, we will be able to diagnose very well in second and late second trimester, but non-duodenal small bowel atresia, level of diagnosis is extremely variable. And this is a study where they felt that in late trimester, if bowel dilatation is not more than 18, and the chances of complete postnatal resolution are there in such type of case, and favorable outcome will be there. And the chances of postnatal surgery is also very less in this group of patients. Thank you very much for patience.
Thank you, sir, for your sharing such an reflective and informative knowledge with us. આવતીકાલથી કચ્છમાં 3 વસ્તુ થશે. તમારા ત્યાં રેફરન્સ વધી જશે અને અમે પીડિયાટ્રિક કન્સલ્ટન્સી કરતા થઈ જઈશું. પહેલા એન્ટીનેટલી અને એન્ટીનેટલ ડાયગ્નોસિસ અમારું વધી જશે. Thank you, sir. Thank you. Now I request our chairperson to give a memento and certificate of appreciation to sir. And charm of your presentation, sir, is long-term follow-up with your patient. Thank you, sir.
I would like to complete the quote Dr. Mayank just mentioned. ઉનાળે સોરઠ ભલો, શિયાળે ગુજરાત, ચોમાસે વાગડ ભલો, કચ્છડો બારે માસ. That means कि कच्छ की जो धरती है, पता नहीं उसमें ऐसे कुछ तो वाइब्स हैं कि हालांकि कोई भी किसी का भी वर्क प्लेस है, जहाँ पे वर्क प्लेस है, एवरीबडी लाइक्स हिज और हर वर्क प्लेस एंड वर्क प्लेस, लेकिन कच्छ में कुछ तो ऐसा है कि वो सबको अपनी तरफ अट्रैक्ट करता है. एक दूसरी भी एक सेइंग है कि यहाँ पे लोग रोते रोते आते हैं और रोते रोते ही जाते हैं वापस. कि जब यहाँ पे भेजा जाता है तो ऐसा लगता है हमें कहाँ डेजर्ट पे भेज दिया, कहाँ काला पानी की सजा मिल गई, लेकिन जब जाते हैं यहाँ से तो भी रोते रोते ही जाते हैं. So, well begun is half done. We would like to start our inauguration session now, and I think Dr. Bhavik, we need some sitting arrangements now.
Running cutting, Samin, like that, cutting. All times that कट दो कर मेरे को कुछ कैमरा ले लूँ खाली स्टेम के साथ कैसे जा सकूंगा देख तो सको क्या इसकी अरे तुम मैं खाली स्टेम लेके दे 2 मिनट लगेगा समझ भाई किसको डिस्टर्ब करेंगे यार
मैम
कैमरा दे दो
मैम थोड़ी कुर्सी पाછળ થોડો આવા જવા માટે વસ્તુ ખાલી કરો હા લઈ લો
वायर ले ये वायर ले पड़ा वाला वायर खा तो जल्दी
चला लो सकते
स्टैंडर्ड अभी स्टैंडर्ड
इधर इकोनॉमी भी रखना बस इधर इकोनॉमी रखना उससे डालने जाने की जगह रखना थोड़ी देर
हाँ भाई
हेलो
To begin with the inauguration ceremony, I would like to invite guests on stage.
ले लेना
Dr. S. Suresh sir, Dr. Mayank Chaudhary sir, Dr. Puneet Khatri sir, trustees from KK Patel Hospital, Keshra Bhai Pindoria, Vice President Shri Kutch Fetuscan Education and Medical Trust, Shri Manji Bhai Pindoria, Secretary Kutch Fetuscan Education and Medical Trust. Dr. Bhavik Khatri sir, Secretary, BOGS. Now we'll begin with the lamp lighting session. दीपज्योति परब्रह्म दीपज्योति जनार्दन दीपो हरतु मे पापम संध्या दीप नमस्तुते. I fold my hands before the Lord, the maintainer of this of creation, in the form of light. I adore this light which destroys all the pains resulting from my omission and commissions. I would request Dr. Puneet Khatri sir for the welcome speech.
Hello everyone. Good morning, ladies and gentlemen. On behalf of POGS, I welcome you all, our esteemed faculties, respected Professor S. Suresh sir, Dr. Mayank Chaudhary sir, Dr. Swati Thakkar ma'am, Dr. Dhiren Thakkar ma'am, Honorable Vice President of Sri K.K. Patel Hospital and Trust, Mr. Kesarabhai Pindoria, Honorable Secretary of K.K. Patel Hospital and Trust, Mr. Manjibhai Pindoria, and all our delegates who have travelled all the way from 50, 100, 300, 400 kilometers to be here in the Fetuscan. This is the first event after I became BOGS resident in Trust before 2 months in April 2023. But doing this type of unique ultrasound workshop was already in my mind since last few months. And Dr. Mayank is my senior and very good friend of mine since our undergraduate and postgraduate times. So I talked regarding this many times with Dr. Mayank. He agreed for the workshop, but he wanted to take the workshop till a higher level. So he suggested to invite his mentor, his guru, and pioneer in the field of fetal medicine, respected Professor S. Suresh sir from Mediscan, Chennai. We invited Suresh sir and he happily accepted the invitation. The field of obstetric sonography has been evolved from the basic ultrasounds being done merely for fetal viability to the advanced and targeted scan to detect fetal congenital malformations and chromosomal defects at the earliest stage of the gestation. And this is the real glory of the field of fetal medicine, that we can evaluate the intrauterine human, and by that we can prevent the birth of deceased and physically or mentally challenged people into our society. Many of us might be doing 10, 20, 30, 40 ultrasounds in a day, but I am damn sure this workshop is going to be unique and memorable for all of us. Many of you might have seen the movie Drishyam 2, I don't know. Many of you might have seen the movie Drishyam 2. उसमें बिगिनिंग में एक डायलॉग है, शब्दों पे नहीं दृश्यों पे ध्यान दो, शब्दों में झूठ छुपने की जगह ढूंढी लेता है, लेकिन दृश्य कभी झूठ नहीं बोलते. इसीलिए सवाल ये नहीं है कि आपके सामने क्या है, सवाल ये है कि आप देख क्या रहे हो. And just in the lecture of Professor Suresh sir, he just said that whenever we see a first trimester scan report, we just don't need to read the report. We have to just see the image. So, क्या देख रहे हो means and today our esteemed faculties will really teach us what to really see on the ultrasound, what to really see on the screen while doing ultrasound according to recent fetal medicine and ISUC guidelines. Once again, I welcome from the bottom of my heart all our esteemed faculties and our prestigious delegates. Let's continue with the workshop. Thank you very much.
Thank you, Dr. Puneet sir. Now, I would like to request Dr. S. Suresh sir to please come and give us some blessings.
I think you're going to hear a lot of times today, but it's a pleasure to be here and especially come out to this part of the country where I've not been there before. And I'm hearing so much about Mayank was explaining what is meant by the word Kutch. And he said how people from here have traveled all over the world and made their mark in different countries. And always something is happening here. Something is happening. And the best time he said, come in winter. And it's supposed to be a very beautiful place. I'm hoping to enjoy that. But having said that, I think workshop in ultrasound, it's almost 40 years since ultrasound started in India, 42 years. And it has transformed so much that I remember in the 1980s, only patients who used to be referred for ultrasound was those who are going to be delivered in the next few days. So I remember the requisitions very well that I'm going to do a cesarean day after tomorrow. Kindly tell me whether there's an anomaly or no. If there's an anomaly, no cesarean section will be done. If there's no anomaly, they will do a cesarean section. This was exactly what was ultrasound in the 1980s. Today, we have gone from bigger the better to smaller the better. And we have come and there are people who have diagnosed anomalies even between 8 to 10 weeks. Some anomalies have been diagnosed. So to that extent, technology has grown and also the field has grown. Our understanding of the fetus has also become extremely good. We not only understand that fetus in its structure, but also in its function. And they have now discovered that fetuses have emotions and they cry, they laugh, they respond to external stimuli, especially respond to external music in different ways. And they've used music as a method of improving fetal growth. And still an unexplored area. And there are several areas which we still don't know. For example, why twin-twin transfusion occurs in some monoclonal twins and not in others. We still don't know. So there's a long journey ahead of us as technology becomes better. We probably will have to understand the fetus better. So it's an exploring journey, and people who are coming into the journey now, as compared to what happened some years ago, a platform has been set from which they can start thinking about what can be done for this fetus for optimal survival in the future. So I think learning is a never-ending process. Thank you for asking me to be here, and I really enjoyed my presence here. Thank you very much.
Thank you so much, sir. And as you said, actually winters are the best time to come in Kutch. So we would like you to again revisit Kutch in winters also. Now going ahead, I would request Dr. Min, sir, to please bless us with his words.
Again, thank you all who are here along with us, and thanks to BOGS office bearer. I'm not going to speak much because you are here to listen academic first. But since last 5 years, every year I am coming to Kutch. I am so much fond of Kutch that I am trying to find one or another reason to Kutch. And somebody told me that if you have not explored one road that you have not seen Kutch, then I asked which road. He told me we have to go from Khavda to Matanu Mud via Hajipur. I said, yes, I will go. Then we started from there. When we crossed Hajipir, my wife was along with me, my kid was along with me, and they were shouting that this road is going to end or not. The road condition was also like that, but we enjoyed that journey a lot. Second time we go to Vigakot. That is also a extreme area with kind of permission of authority. Third time I thought I should come and visit a technology of Kutch, this green energy and all those things. And I come here and I visit Gamesha and Siemens and Adani plantation, and my kid was along with me. And he was inspired in such a way that he chose that I will choose my career as a renewable energy engineer. And then we take admission at he's at present Canada. He's pursuing renewable energy as a branch as his career. And again, this is one more year I am in Kutch, and I also am fond of Nanu Run of Kutch. The terrain is different. I go there. I drive car at 100 kilometers speed, and there is no obstruction. There you can drive to 20-25 kilometers. So again, that is also my favorite. I am very much fond of Kutch, and I will be in search of reason to come next year also. Thank you very much.
एक्चुअली सर अमिताभ बच्चन भी कहते हैं कि कच्छ नहीं देखा तो कुछ नहीं देखा, और कच्छ हैज प्रिविलेज टू बी द लार्जेस्ट डिस्ट्रिक्ट ऑफ इंडिया, सो द रोड गोज एंडलेस. Now I would request Dr. Puneet Khatri sir to please hand over our token of love in the form of a small memento to Dr. S. Suresh sir. I would request Dr. Puneet Khatri sir to Dr. Bhavik Khatri sir to give a memento to Dr. Mayank Chaudhary sir. All the finances are with our treasurer, Dr. Madhav Hirani. So I would request Dr. Madhav Hirani sir to pass on a check and memento to the trustees of KK Patel Hospital.
Sir, can you close some? Yes. Wait. Ten. Thanks.
I would like Dr. Bhavik Khatri sir for Thanksgiving.
I was supposed to say good morning, everyone. No, now it is good afternoon, everyone. I extend my gratitude to Dr. S. Suresh sir. Sir has traveled 2200, that is 2,200 kilometers for us. Sir had a conference on Friday. He completed the conference the whole day. Then he traveled through the night just for us. He landed in the morning in Ahmedabad, and from Ahmedabad he traveled more than 5 hours just for us. So kind of you, sir. This is more than enthusiasm. This is purely a love from your side, and we express our gratitude for you. We are thankful to Dr. Mayank Chaudhary, sir. Mayank, sir, is the one more master of visionary man for this particular workshop. Dr. Puneet Khatri, sir, wanted this to happen, but Mayank, sir, put all his efforts behind this. He was taking constant follow-ups for everything. ભાઈ તે બધું બરાબર કર્યું છે, આ બધું બરાબર તમે કરતા જશો, પણ તોય હું પૂછું છું કે આ બધું બરાબર છે, હોલમાં લાઇટિંગ પ્રોપર છે, આ છે તે છે. So he was taking so follow-ups. He was just worried કે આ બધું શાંતિથી પતે. તો આપણા માટે જે એટલું સારું વિચારે છે, we are really grateful to you, sir. We are grateful to Dr. Swati ma'am, Dr. Dhiren Thakkar, sir. We are thankful to KK Patel Super Speciality Hospital, Bhuj, અને એનામાંથી ટ્રસ્ટી કેશરાભાઈ પિંડોરિયા જે ટ્રસ્ટના વાઇસ પ્રેસિડેન્ટ છે, અને મંજીભાઈ પિંડોરિયા કચ્છી લેવા પટેલ એજ્યુકેશન મેડિકલ ટ્રસ્ટના ટ્રસ્ટીમાં સેક્રેટરી છે. એ સિવાય એડમિન્સ પ્રદીપ ભીંગરાડિયા સર, ચિંતન મહેતા સર. એડમિનમાં આ બંને જણાનો ખૂબ સારો સપોર્ટ રહ્યો. આઈટીમાંથી કિશનભાઈની ટીમ, માર્કેટિંગમાંથી આલપભાઈની ટીમ, મેન્ટેનન્સમાં સત્યપ્રકાશ તિવારીની ટીમ. આ બધા, અને આ તો એન્ડલેસ નામ છે. છેલ્લા 7 દિવસથી થ્રુ આઉટ દે આર કોઓપરેટિંગ ઇન સચ એ વે. ઘણી વાર તો અમે આમ ટ્રસ્ટ ઉપર દાદાગીરી કરતા હોય ને એવું અમને ફીલ થતું, પણ તોય they were cooperating like anything. We are thankful to Gynec Department of Adani Institute, Ashraf Mehmet sir, Prafulaben Bindi ma'am, Nidhi ma'am, Dharmi ma'am, Rishikesh ma'am. They have worked very hard to search patients for us. Audiovisual team, Hasbil bhai, Kapil bhai team, we are thankful for you people. You are doing wonderful job. Then services we have Siddharth staff from Padmavat Decors, and food we have Tapan Rathi from Cook Caterers. We are thankful to them as well. And the delegates and the PG students who have traveled not only through the Kutch but outside the Kutch as well. એક નાનકડો છે ને આપણે ક્લાસરૂમ યાદ કરવાના છીએ. હું છે ને ગામના નામ બોલીશ અને જે લોકો હાજર હોય ને એ પ્રેઝન્ટ સર કરીને ઉભા થાય. પાલનપુર, જમવા ગયા. ઉદયપુર, યસ. વડોદરા, બનાસકાંઠા, અમદાવાદ. ઉભા થાવ મેડમ. અમદાવાદી, મહેમદાવાદ, યસ. લવલી, નવસારી, તળાજા, બ્રિલિયન્ટ, જસદણ, લવલી, ગીર સોમનાથ, એક્સેલન્ટ, રાજકોટ, સુરત, બોટાદ, યસ, વેરાવળ, સાવરકુંડલા, બિલીપુરા, ભાવનગર. These are not mere the names, they have actually come and traveled just for this conference. Oh my God, big round of applause for all the delegates and students who have traveled just like this. Last but not the least, we would like to thank the supporters of this event, that is Wipro G, Metropolis Laboratories, Genworks, Bismarck Pharma, Unison Pharma, Bayer Zydus, Crystal Pharma, St. Morrison, Curil, Lift Life, Topic, and Madsen. Thank you once again. Okay, now let us move ahead, and I would like to hand over this mic to Hall in charge.
So move ahead. I'll hand over the mic to Dr. Anuradha and Dr. Mittal for next program.
Hello everyone. On this beautiful afternoon, I, Dr. Nurada, welcome all of you to this brainstorming conference, Kutch Fetuscan 2023. So, our heartfelt thank you to all the delegates and our allied guests. I would like to start the today's session by inviting today's speaker, Dr. Swati Chakka. Dr. Swati.
She's in demonstration.
लाइन कट कर दे बाबू
So, Dr. Swati did her PG from BS Hospital and Fetal Medicine Fellowship from the Mediscan System, Chennai, training at King's Hospital, UK, and at present working as a consultant fetal medicine expert at Mayflower Hospital and at Harish Doshi Sir's Clinic. Can we have a big round of applause for Dr. Swati?
पिता खरो
चालू છે કે નથી ખબર નથી મશીન એનો
मैं को बैटरी
The screen that you are seeing right now is the screen of yes, G Wipro Volution E10. It is the demo ultrasound machine today, and the live demo has started. Hope my voice is audible by Dr. Swati. Ma'am, તમે સાંભળો છો મારો અવાજ? If yes, you have to speak through the collar mic that you have. Astal bhai, collar mic અપાઈ ગયું છે? તો ક્યાંથી બોલ?
हाँ चल अलग कर दे दे उसको
The demonstration of fetal first trimester scans will be followed by interesting cases by Dr. Swati ma'am.
Hello.
Hello.
Yes, am I audible?
Yes, ma'am.
Okay, thank you so much. Okay. Shall I start now?
Yes, ma'am. You can start.
Okay. A very good afternoon to everyone. So I'll be demonstrating a first trimester scan today. I'm scanning on E10 Volution machine with C2-9. Hello.
Hello.
Yeah,
Hello,
am I
ma'am.
audible?
Yes, ma'am.
Yeah, okay. On C2-9 probe. Okay, so let's start with the scan. She is a second gravida with previous one miscarriage and has come for the first trimester scan. So as I said, when you start the scan, always start with the survey. Survey means you check whether it is an intrauterine pregnancy. You can see the uterine lining here, the location of the placenta, it is anterior. The fluid subjectively is normal and there is one fetus and the cardiac activity is present. Even in the fetus, go from bottom to the top or top to the bottom. Now let's start with the scan. So since the baby is in a good position, I am trying to take crown rump length. No, it is in a flex position. Okay. So,
Dr. Swati,
yes,
if baby is taking your start looking that.
let us
Many
start.
time baby take our exam particularly in workshop.
Okay, so let us start with the head sections. So, in head, this is a transventricular plane wherein you can see the calvarium is intact. This is midline falx. You can see here, these are two choroid plexus nicely fitted into the place, and you can see this third ventricle many a times, which is a normal finding. Now going towards the transthalamic plane, here you can see two thalami, cerebral peduncles, midline falx again. This is cerebral aqueduct of Sylvia, and this is the plane where we measure biparietal diameter and occipitofrontal diameter. As you can see here, biparietal diameter from outer to inner or outer to outer, and occipitofrontal diameter from outer to outer. Now, when you rotate the probe, you can see, okay, now the baby is in a position. Let me show you the heart. So for heart, always box zoom, and first and foremost thing is to check for the situs. Now situs we take in 4 planes. First is the abdomen, second is heart on the same size as with the stomach, third is the position of the baby, it is in head up position, and fourth is the direction of thalami, should be in same side of the spine. So this is the first section, spine, stomach, spine, fetal heart on the same side as the stomach, thalami, and head up position. So once we have confirmed the situs,
So this is pushing you one step ahead.
yes,
We are looking for a second trimester situs. Now, how it can be seen in first trimester also, it was very well demonstrated.
yes. Now even with the grayscale you can see 4 chambers of the heart, beauty of this probe and the cooperative patient.
Your patient is fetus.
Yes. Now 4 chamber view in color, you can see 2 inflows, 2 symmetrical inflows, and an arch view.
So many times this happens when you put a Doppler, baby start dancing due to Doppler energy. It is making life colorful.
Yes. So when you go forward from the 4 chamber view, you can see an arch view, that is a tick sign. The tick sign is made up of 2 hands, the longer hand and the shorter hand. The longer hand is a pulmonary arch and the shorter one is the aortic arch. So these are the 2 views for the heart. So nicely now we can see the 4 chamber and the arch view in color. Now for cardiac activity or for tricuspid regurgitation, the sample volume should be 2 to 3 millimeter at least. Angle insonation should not be more than 30 degree. Baby is jumping. Try to take or try to sample the. Let us not harass the baby and go to the anatomy. So in abdomen, here you can see the stomach bubble and anechoic structure in the left upper abdomen, Can also see this is a diaphragm. This diaphragm, and the stomach is well below the diaphragm in the left upper abdomen. Can also see the bladder here. This is a bladder in lower abdomen, which you can confirm by putting a color flow. Here is the bladder and 2 umbilical arteries, but as I said, even if you see single umbilical artery, don't mention that in your first trimester scan.
Can you create an artifact of bladder with pelvic bone shadowing? Because
Yes,
here
yes.
bladder is very small.
Yes, yes, sir. That is very much possible.
Show if it is seen.
See,
See,
this is an
this is-
artifact of the bladder. With
So
the shadow.
please beware of this in first trimester.
Yes,
Don't consider this as a bladder.
because the bladder will have two nice echogenic lining. This is actual bladder.
Yes, he did it.
Now, here we go. So, as I said, one must always take cine loop. So, even if the baby turns in a while, you can take your images from that cine loop. So, for example, this is the image. Anti looks nice in this image, but if you see here, here is the zygoma. So, this is not a pure mid-sagittal plane. So, if you have taken a cine loop, you will go through your loop and see that this is a mid-sagittal plane wherein the zygoma is not seen. You can see 3 lines: the top of the skin, nasal bone, tip of the nose. This is an intracranial lucency. This is brainstem, choroid plexus, cisterna magna, and a nuchal translucency. Caution must be taken that the nuchal translucency is actually a nuchal translucency and not the amniotic membrane. You can measure the nuchal translucency manually, caliper on to on, or you can also measure it with a sono-NT measurement. Now, from this plane, mid-sagittal, if you go exactly 90 degree, you will see 2 orbits with eye lenses. These are 2 orbits with white structure inside is the eye lens. And if you go a bit forward, you can see premaxillary triangle. The top of which is nasal bone, maxillary processes, maxilloalveolar ridge, and mandibular bone. So hard palate, if has a cleft, can be diagnosed here if there is a gap at the base of the premaxillary triangle. Another technique for nuchal translucency, when you are taking this choroid plexus view, you turn the probe 90 degree and you will see the nuchal translucency. Now, for limbs, We take limbs in dual image. Humerus of one side, humerus of other side, radius and ulna of one side, radius and ulna of other side. Hand on one side, and a hand of other side. As I said, that open hands can nicely, or orientation of hands and feet can nicely be seen in first trimester C. This is an open hand of one side and the other side. A cord insertion. And for lower limbs, same way, femur of one side, femur of other side, tibia and fibula of both sides, foot of one side and of the other side. For talipus, there should be a liquor here around the feet. So let's wait for the baby to turn for that. Never ever take CRL in such a position. Here nicely you can see the diaphragm and the stomach.
Can you try ductus in
Yes,
this?
yes, that's what. Yeah, so while trying the ductus, the bumps of the baby should be upwards. So you don't have to change the angle of insonation. So, an aliasing area here is the ductus venosus. Once you put ductus venosus, baby will definitely try to jump.
Why you keep this sample gate as small as possible? What is the reason for that?
So you are avoiding the contamination from the surrounding vessels. To keep, reason why we are keeping the sample gate small.
Keep color box slightly bigger and lower side. Cameraman is there or not?
No, cameraman is not there. The baby is jumping a lot while taking the ductus venosus.
Okay, try it. You try.
Yeah.
You try.
So in first trimester scan, you don't have to go more laterally, because we'll be seeing the uterine artery just besides pubic symphysis. You just have to tilt the probe. This is the cervix. I'm tilting the probe on the left side. Here is my uterine artery.
Try to keep box slightly bigger. Slightly bigger.
Again, the sample gate should not be.
Sample gate. So many times in this area there are a lot of vessel. So what you have to do, you have to increase PRF at least where the velocity is around 60. So that small vessel will be filtered out.
Yes.
Otherwise, it is quite tempting to put a sample gate at various vessel where velocity is less than 60. That there is possibility that there is
You're in
not
a branch
uterine.
uterine.
And there is a need of manipulation of probe slide, that you have to create this oblique vessel to as vertical as possible. Okay, so again there will be a true PSV if you do like that. This is slightly oblique uterine. Try to manipulate a probe and make it vertical, just for showing the angle correction. Increase PRF. So here there are lot of vessel are same. If you will increase PRF, the પરચુરણ વેસલો છે ને બધી એ જતી રહેશે. એટલે આપણે જે ઇન્ટરેસ્ટ વાળી છે ને એ જ રહેશે, પરચુરણ જતી રહેશે બધી. I think all the essential thing which we can see in this odd 20 minute is covered.
Yes.
And except fetal face, particularly fetus lips, we have done anomaly scan in this baby. Whatever we were able to achieve at 20 weeks, almost everything we have achieved in this case. So thanks to expertise, thanks to machine, and thanks to baby also. So can you do you want to show anything else, or we can move to next session?
You can move to next session, sir.
You have to come here.
Yeah, I'm coming.
If you want to show something specific, just finish and please come.
Yeah, thank you so much.
Madam, can you show me the landmarks of cervical length in first trimester? And would you like to say a few sentences about importance of cervical length in first trimester?
Yeah, cervical length definitely is important for preterm labor. So we do take cervical length transvaginally routinely, but here, since the bladder is full, we can see the cervix even from transabdominal view. So this is an internal loss.
So it is a good idea to see the cervix transvaginally only.
Yeah.
Because if you see transabdominally, a lot of artifact chances is there. Suppose the first artifact will be created by this full bladder. There will be a hydrostatic pressure. Then the second artifact will be created by people like me. 2.5 kilo ka hath. Barabar? I will put that probe and that pressure will again increase the cervical length falsely. So that is a pitfalls of transabdominal scan. And some detail, this is a good patient. You are able to see anterior lip, posterior lip and endocervix.
Yes.
But this you will not able to achieve in a majority of case. So it is a good idea, if you want to see the cervical length, please do transvaginally.
Madam, when we were measuring uterine artery Doppler
Yes.
studies and everything, I could appreciate that the PI was around say 2.0. So would you like to comment on that particular thing, or you want to just take a median and then comment?
So when you are taking a uterine artery, previously the concept was of a diastolic notch, but nowadays, since past few years, we do consider mean PI. If it is more than 95th centile, that is something to be considered for.
So you want to rely more on the charts than labeling it as high resistance.
Yes.
Yes.
We do follow nomograms. Actually, we are using Sonocare software, which itself has those nomograms. So when we plot uterine artery inside, we can see the percentile. So we do follow those percentiles. For example, say right uterine artery is more than 95th percentile and left is normal. We do check mean uterine artery PI. If it is more than 95th percentile, we advise ecosprin 150 milligram.
Madam, one last question.
Yes.
When we do the uterine artery Doppler, we will get PI, RI, S upon D ratio.
Yes.
But usually the ultrasound Doppler world runs on PI.
Yes.
So why PI?
So that is a pulsatility index.
Okay, the reason why we use PI instead of RI, the calculation of PI is peak systolic velocity minus peak end diastolic velocity divided by systolic velocity. Okay, PSV minus EDV by PSV. So when you do that, supposing there's absent diastolic flow, then the end diastolic flow will become 0. Okay, when you use RI, which is A minus B by A. Okay, when you do A minus B by A, this peak systolic velocity, end diastolic divided by the peak systolic velocity, that is the RI. If end diastolic velocity is 0, then the value becomes 1. In PI, you take the mean velocity over the cardiac cycle. Peak systolic velocity minus end diastolic velocity divided by the mean. So you'll always get a value. Supposing there's a reverse diastolic flow. In reverse diastolic flow, the RI cannot calculate because it doesn't take negative values into consideration. Whereas PA takes the negative value also into consideration because it's the mean velocity over the cardiac cycle. That's why RI has been made obsolete almost like 20 years ago now. Yeah.
Swati, please come.
Yes, sir.
Here,
Come.
people are here waiting for your interesting case.
Few reassuring words for Dr. Swati. Your lecture is ready on the laptop and is very nicely prepared by Dr. Dhiren sir. बहुत सरस ट्रेनिंग તમે આપી.